Yes, Mr. President.
All comments should address a matter related to Kingsville Public Schools. The school board will not hear public comment that involves a complaint about an individual staff member, a personnel action, a student disciplinary matter, a complaint about an individual student, or pending litigation. In the event your comment in the judgment of the presiding officer constitutes a complaint against an employee or officer, the presiding officer will interrupt and ask you to stop and direct you to proceed with the district's formal grievance procedures. The board expects that each speaker will be courteous, modeling for our students how one can respectfully disagree with others' views. Speakers will address their comments to the entire board and not to one individual board member, nor to the superintendent, to a staff member, nor to the audience. Speakers will not engage in personal attacks. Speakers will present their comments from the podium provided for them. With these cautions in mind, we will now be glad to hear the general comments. And our first speaker will be John Temple.
We don't have a mic.
Okay, well, I'll talk loud. I worked here for 13 years in Kingsville, and I had the great pleasure to work with Joe and Jacob and Miss Salinas in Robstown, and they're finest people you would ever know or want to know. But my question was, maybe I can get an answer, maybe not. What in the world is the problem with withholding the scores? They're not going to change. If you withhold them 5 more years, they're still going to be the same. You know what I mean? I mean, my opinion is let them out there and start doing what you got to do to get it right. You know, I mean, I can see no reason to keep filing a lawsuit, you know. One of these days, some judge is going to say, release them. You know, I don't know when, I don't know where, but one day someone is going to release those scores and they're going to be out there. And I think that most of the people here kind of know what they might be or have a good idea, because you don't hide good scores. You know, if they're 80s, 90s, you don't hide that. And what else? Oh, it's the same for everybody. Everybody else went through the same process and had the same rules, the same conditions, the same this, the same that. So I don't see why it would be any different for us, because there are more districts that didn't take part in that lawsuit than did. Many more that didn't. And I'm sure some of those schools didn't have like the greatest scores either. I can't see it myself. And I also don't see, and I'd like to know, and I know it's public information, how much have the lawyers cost us on this? They ain't working those things free. That there has to be a cost to that. And I mean, and that's public information. You know, anyone in this room that lives here could go ask for that and get it. I don't have any idea how much it is, but I know lawyers are $300-400 an hour, and I know there's been many hours, so that's a lot of money, and all we're getting is postponing the inevitable, because they're going to be released. There's no question about that. They will be released. And the lawyer, I had that. And what else was I going to say here? I had one other thing, and sometimes I can't even read my own writing. And let's see here. Oh, and I also want, and I talked to Miss Moore a little bit ago. And I know, I mean, I was a principal in Cotulla for 7 years. I was also an assistant principal in Robstown for 13 years. I know a little bit about it. And I wanted to publicly tell her, I mean, I read a lot of baloney that everybody reads about this, and my kid's not going to pee his pants, and you can make it. I asked her, and I told her she needs to keep that up. That should have been done out there a long time ago. You know, because I mean, I worked out there about a couple of years ago for 2 weeks because I have my SPED certificate. It was a zoo. I'm telling you, a flat zoo. Every place you went, there was 20 kids lined up sitting there, 20 kids over there. The toilets and the urinals were ripped off the walls, and you couldn't say anything to them. You know, I had retired, so, you know, I told my wife, man, I don't have to put up with this. Like the second day I was there, they had a lockdown. So I know what lockdowns are. Well, this kid gets up and walks right out the door, just like he was going to the bathroom. So I go over there and I stand in front of the door, so that wasn't going to happen again. And I'm not a small individual. So all of a sudden somebody was knocking. Well, I'm sure it was that kid. The security probably ran him back, but I didn't open the door because you're not supposed to open the door. Oh, that's my 5 minutes. Well, anyway, a girl told me F you, but she did not leave off the last 3 letters.
Thank you, Mr. Temple. Our next speaker will be Elizabeth Ramos.
All right. Good afternoon, members of the board. On the agenda tonight is some insurance stuff, but I wanted to touch base on the superintendent evaluation. I'm familiar with that as being a prior board trustee. So when you guys go back in executive session after your workshop, and I know you've seen the paperwork, and I hope you sat down for more than 5 minutes to fill it out, but I want you to ask yourself, why aren't the superintendent goals measurable? You've had them for 4 years, and none of them are measurable, especially from 1 year to the next. How are you going to grade someone if you don't have a goal? So that's just kind of ironic that you have superintendent goals, but I'm pretty sure none of your evaluation has an actual goal on it anywhere. So ask yourself that. Also, when you're back there, ask, does any of the goals that we have pertain to student achievement, such as grades? So if Sally makes a 60, is Sally improving, and by how much do we want her to improve by? You don't have any measures that we want Sally to improve by 30% in this amount of time. Guarantee you don't have any of that on your superintendent evaluation. You guys need to press the president and whomever you work with, such as your attorney or any of the TASB people that you work with, to have goals that are measurable, that aren't written for the person. It should be for you guys and for the student success and success of the community and the school. So while you're back there sitting back giving each other who got what grade for what on this goal, ask yourself, was it an actual goal? Think about that for a moment. And if not, what are you guys doing for the community if you don't have any goals in place? And then I know that when you guys read out the rules for this and tell people to go file a grievance, just know you have many grievances out there at a level 3 that have not been heard in over a year. So you can tell us to do something, but it still won't get done. You guys won't hear anything. You guys won't even know about it. Same thing with your superintendent goals. Pretty sure there's a lot of stuff on there that you ask yourself, well, I don't know. No one's told me. How am I supposed to sit here and score if I don't know? So think about that. I'm going to leave this short and sweet because this is pretty much my end. But I know there's been say that only 1% of the community complains, or only 1% of the employees come and complain to you, Liz. I'm going to sit here and do mathematics, and I could tell you I know how to times, and I know how to find out my percentages, and it's way more than 1%. So I'm going to speak for those people and end you with a quote. And so while you're back there, think about that. Think about the quote that I'm just saying here and just think, Liz made a point again. I made a point again. Liz is right once more. Okay, what am I going to do to change that for everybody? we, the unwilling, led by the unknowing, are doing the impossible for the ungrateful. We have done so much for so long with so little. We are not qualified to do anything with nothing. Have a good night.
Thank you, Ms. Ramos. Our next speaker will be Scott Hamilton.
So for y'all that don't know me, I'm a biology teacher at the high school. Second year teaching, had a whole career, basically retired as an executive with Wells Fargo, Bank of America, worked at home, basically was able to do that. Decided I wanted to help students, and this is where I'm at, okay? So I do this because of this, like a lot of us do it, okay? I'm gonna start this with good news, okay? Good news. We have Miss Moore over here. He's a great principal. She's coming in trying to make changes. There's been a lot of talk about the new tardy policy that she just dropped on the school that we're going to implement in another couple of weeks. And there's been a lot of blowback. As a teacher, it is the best thing that has happened in a long time. We need to support her on it, and we need to continue doing it. Because I will tell you as a teacher, I used to have to prepare instruction for around 45 minutes for a 54-minute period. You know why? Because the rest of the time I was trying to get all these kids tardy into my classroom because they're roaming the halls. Guess what? Yesterday I sat there with 10 minutes left of class with nothing to do because I didn't prepare for it. Because I got my kids in the classroom. I want y'all to know that that is a great policy. It has worked well for us. They are starting it. There's lots of things that they're trying to change and implement into it, and it's being developed. But we're moving in the right direction, folks. We're trying to get in the right direction, and this is just the start. And I wanted the board to know that, and that's why I came tonight. So thank you.
Thank you, Mr. Hamilton. Our next speaker will be Thelma Hernandez.
Good evening, everybody. A lot of you already know me because I've been in this district 37 years. So had a lot of your children. Now I'm getting grandchildren. So I love this district. And I do want to say that I do support Mrs. Moore with this new tardy policy. We have, it's hard to teach kids when they're not in class. And yesterday I read from our principal exactly what she sent to us. So verbatim, I said, this is what's going on. This is why we're doing it. And I even said, you know, guys, I come in and sit down and try to take attendance. And what happens? Because I have a doorbell. So I can't really, the kids are getting kind of like tricky, sneaking on us. They pretend that they knock on the door and they like, oh, they didn't let us in. That's why we're in the hall. So now I have a doorbell. So they can't use that excuse. So I come in, the doorbell, I sit down to try to take attendance. Ding dong. To go, open the door, let a kid in. I go sit down and try it again. Ding dong. And I told the kids, do you not see me do that all the time? And they're like, yes. I said, this is what we're trying to stop. We need you guys in the classroom so we can teach you. I can't teach you when I'm running around opening the door every few seconds. So they see it. Everything is moving. I know there was a lot of lashback on social media because some kids are posting because they're upset. They're upset because we're putting them to the test. We're putting them, make sure you get to class. I even asked, how's the vaping thing going? You know what? Ever since the kids don't have a chance to go vape, it's dropped to like 5 people today when it used to be 20 or 30 like in minutes. And we have our security guards having to go figure that out, or principals have to go run to the bathroom and find out who's smoking. I've been gone in there when I smell and said, oh my God, people are in here. That has stopped. I mean, it's gone very limited. So I know people in the community are upset. I said, this is what I want to say. Do you want your kids in the classroom learning, or do you want them out vaping and doing things they shouldn't be doing? I mean, that's what our community needs to find out. What is it that you want us to do? Do you want your kids to learn and be successful in life, or do you want them in jail somewhere else? Because they're not going to move forward. So I praise Ms. Moore because we've been complaining. We're like, when are we going to do something? So she decided in 2 weeks before, and right now it's a soft start. They're not being punished. We've heard that people are being suspended and all this crazy stuff. It's not happening. 2 weeks, it's a soft start. They get a chance to learn. This is the expectation. In my classroom, my kids know their expectations. They know that better be in my class, better be seated, etc. Now I want all the other students to get there into those classes and be, ready to be good for the day. Okay? So that's what I need our community to focus on. Have the kids in the classroom, have the kids learning, have the kids get a great. Kings ISD is like one of the best. I hate to say it, but my daughter's in med school. She's doing great. We have great kids in our system. We got great teachers, but we're always getting bashed over and over and over. And it's time for us to stop being bashed. We're a good community. We have great people in our work. And like I said, I led this district. So thank you for listening to me. I get emotional, but I do love this district and I do love our students. And we need them in the classroom to learn. Thank you.
Thank you, Ms. Hernandez. Our last speaker will be Joseph Acevedo.
Good evening, everyone. My name is Joseph Acevedo, and I just wanted to start by expressing my gratitude to Kingsville ISD for the warm welcome I have received. I did come from Jubilee Academies, the charter district here in Kingsville, and it has been such a tremendous experience, working alongside, so many educators who truly value education. I also wanted to speak about our tardy policy that was implemented, yesterday, and it got some news on social media and things. However, the goal of it has been to increase instructional time, to make sure that our students are in the classroom and they are learning, to keep them accountable to that. We've looked at the data. We've looked at attendance data. We've looked at the grades, failure rates. We've looked at our, EOC scores, and we've looked also at the amount of students who have been, suspended or in DAP for things like vaping. And when, students are going to DAP, or there's distractions, or there's frequent absences or missing class, there's missing instruction there. We are here, as Mrs. Moore has said, to work on and provide growth within our campus. That is our goal this year, is that our students' attendance, the discipline, the our EOC scores, that we see growth in a positive way. This is the purpose of our new tardy policy, to make sure students are where they need to be. And I will say, we did see, images of long lines yesterday and things like that. But as a, former elementary principal at Jubilee for 8 years, just think about Driveline, right? The first day of school, that Driveline is always so crazy and chaotic, but you give it time and the system starts to work. We start to work out the kinks. People get used to, what's in place. And that's what's happening here, where we had the long lines yesterday, we had much shorter lines today. And as we continue this week and into next week and beyond, we will see shorter lines as well. Again, the goal that we have is to increase instructional time and make sure our students are where they need to be, receiving instruction from the finest educators in this area. And I will say as well that it has been truly an honor to work under the leadership of Mrs. Moore, and also to work alongside, tremendously very experienced and great assistant principals, my fellow assistant principals, Mr. Steven Salinas, Ms. Velma Salinas, and Ms. Debbie Winslow, who were all committed to ensuring that the needs of every child at HM King is met. Thank you.
Thank you, Mr. Acevedo. All right, we move now to item number 6. The Board of Trustees will conduct a workshop to discuss the following: TRS health insurance, Aetna, and health insurance benefits. I will turn it over to Dr. Pitts.
Thank you, Mr. Gufall, Dr. Pettis, members of the board. Let me talk a little bit about where we are in our health insurance timeline, and then we'll talk about the schedule for tonight's board workshop. So we are approving next Monday, and what we will be approving is a couple of things. We will be approving, number one, how long we are going to renew our self-funded plan, whether it's for 8 months or 12 months. And then number two, we will be also approving what is the plan design going to look like, and we presented you with the plan design the last couple of weeks, and what are the premiums going to be like as well too. The reason why we have kind of a tight timeline right now is for several reasons. One, we have to work on programming the benefits software for open enrollment, which will be happening within 2 months. And then also we need to set up with our self-funded plan. We need to sign an agreement whether we're going to be continuing for 8 months or 12 months. So tonight, the schedule is number one, we're going to have presentations by TRS, which again is something that we don't have much experience about. So they have a presentation that you've had in your packet. Number two, we will have Aetna speak as well. They're here too. We know a lot more about Aetna because we've been with them for, I think, 5 years now, somewhere around there. And then number three, we will have a discussion and we will talk about the financial ramifications of either self-funded or fully funded with TRS. And we will also have our health insurance consultant talk a little bit about the plan that we currently have and what we can do to make the plan run a little bit smoother. So without any other further ado, let me ask TRS to come to the podium and begin their presentation. Again, we ask that you keep your presentation within 30 minutes, then the board will have time for questions afterwards.
So good afternoon, Kingsville ISD and board members. On behalf of Teacher Retirement System, we'd like to thank y'all for inviting us out so y'all can learn more about TRS Active Care and why we should be the plan of choice for you as you're making these decisions. So before I get started, I'm going to do quick introductions of who is here on behalf of TRS tonight. So my name is Monica Bernal. I think I went around the room and introduced myself to most of you. I am the Senior Director of Health Operations at TRS. I also have Marisa Campuzano. She is the manager of TRS Active Care Operations. And we also have Clayton Easom. He is with Blue Cross Blue Shield, who is the health medical administrator for us. He is a district ambassador. And we have Nestor Hinojosa, who is with Express Scripts, the pharmacy benefit manager who administers that for TRS. And he's also a district ambassador. And both of them will be talking a little bit more about their roles throughout this presentation. So as I said, we are here really to explain to you why TRS Active Care should be the plan of choice, why you should consider us for your health plan. So we're going to really go through tonight and talk about the advantages of active care, which includes our affordability, our active care benefits, our district resources. We'll leave some time for Q&A. So we know we're under a tight deadline here. We have presented y'all with these slides in advance. I know Marisa has been in contact with some of you already to answer some other questions. Because of the time constraint, we will be skipping some slides or skimming over them, but we're happy to answer additional questions. So to begin with, and we think about this and say, you know, why should TRS Active Care be the plan of choice for y'all? And really that boils down to the superior quality we offer, our stability, we're educator focused, and our innovative approach. So what each one of those means is that when you look at the quality of TRS Active Care, you compare us to what's out there nationwide, we are really positioned to deliver the best cost efficiency, and we do not sacrifice that quality within TRS Active Care plans. So what that means is we really focus on the quality of what we are delivering to all of the participants in active care. Our stability, you're going to hear us tonight talk a lot about the size of active care. What that is those are the participants we have in our pool. So over 420,000 participants in our pool with 974 districts. Because of that size, it actually does give us that leverage to negotiate better rates. And we'll talk about that and have a stable plan that we are able to offer to all of the plan participants. We're educator focused on this. Our plan is designed around what the educators need. We get that information from y'all, which also leads into our innovation. We are designing these plans with the benefits. We are taking the feedback from our school districts so we can plan, so we can structure these plans. An example of that, Marisa works on some surveys that she sends out to our actively enrolled school districts. And we're asked, what do your educators need? What are they asking for? Now, we can't guarantee we'll offer all of it, but what we can do is look into those and see what we can work with Blue Cross Blue Shield and Express Scripts that we can offer without sacrificing increased premiums or sacrificing any of the plan delivery that we have for y'all. Continuing on with why we are in that position to be in an advantage, why TRS Care is that choice for you. We have those below market costs. Even before we take in any federal fundings, our plans are on average 14% lower than those non-participating districts. What that translates to is lower premiums that your employees will pay, lower cost on the school that you have to pump into Active Care to fund those premiums. So in the past couple of years, TRS plans, we've experienced half the cost growth of all of those competing plans out there. So what that means is because of the way we manage the plans, yes, we have to adjust rates with market and so forth, but on average, ours are that much lower compared to that competition out there. So we are also highly efficient. As y'all all know, there is administrative costs with running a plan, right? Ours, we pump in 97% of every dollar that comes into Active Care back to the plan. That means only 3% of that goes to the administration of those plans. You compare that out in the market, those numbers are in the double digits, and I'm sure y'all have seen that as well. We also work very closely with TRS, internally our operations, with Blue Cross Blue Shield, ESI as well, to be efficient, to reduce fraud, waste, and abuse, and also to negotiate some of the best rates out there so we can pass those savings on to y'all. So also we are, and we like to focus on this, the plan of choice. 99% of the education employers chose to stay into TRS Active Care health plans. So that equates to 1 in 67 Texans who are in Active Care. And as I said, about 952 school districts are currently with us. As I mentioned earlier, we do leverage our size so we can negotiate those better rates. What that really means is because we have so many participants in our plan, we are able to do those network negotiations, really lower those costs that come out to y'all. We can lock in those premiums well in advance of the plan year. We get those to y'all so you can make your decisions before the plan year starts on 9/1. Because we are so big, also, we eliminate the need for you to get that stop loss insurance. Where that really comes into play here is when you have those high cost claimants that you have to take on. You know, we hate to admit this, but they happen, the high cost claimants. You get, for example, a neonate baby, and you get a baby in there, and God forbid it happens. That's an easy $1 to $2 million of costs that you will have to absorb somewhere. Because of the size of our plan, that is spread out against our entire 420,000 people. So it actually is very minimal, if that you will feel from having that. Smaller school districts, you are going to feel that the next couple of years, you're going to have to raise your premiums to really offset those high risks that you do get. As I said earlier, we have those low administrative costs. We have that ongoing rate stability. And also, we really want to focus on this. Y'all have a lot on your plates right now. Give us that burden, that administration to monitor this plan, to do all of the administration on that. Y'all had several folks in here presenting tonight. Y'all have a lot more priorities going on in your school district. Let us take over your health plan and manage that from beginning to end. Let us work with your benefit administrator. Let Marisa step in so she can take this on and make sure that y'all are all well informed of the TRS Active Care plans and that your employees have the best health insurance out there. So with that said, I am going to ask Marisa to come up here as our Active Care Operations Manager. She will be the point of contact. So I really want her to continue on with the presentation and share a lot more information with y'all.
So along with leveraging, so we have the TRS Active Care Advantage, shaping the new generation of TRS health plan. As Monica stated before, we are looking at ways to innovate. We survey our districts. We find out what it is that their employees want to see. And we take that back. And one of the things that we took back along with this innovation was regional rating. So that came about because we met with districts. This is what they wanted to see regionally for their employees. So that's one example of how we're doing that. And we survey them every year to get that information. And this just goes back into the regional rating methodology, what we use to get those rates for those regions and really get into their populations and dig deep into their claims so that we could actually offer them lower costs based on the region that they're in. This slide talks a little bit about Texas Plan's experience, how the growth looks on a self-insured Texas plan versus TRS plans. As you can see here, 40% growth in self-insured plans compared to 20% on TRS Active Care. Right here in this slide, you'll see that TRS Active Care offers lower total rates. So in this illustration, you'll see where employer contributions and employee contributions combined are still lower on the District B in Active Care versus District A, which is an outside plan in TRS Active Care. If you were to look at these plans and look at both of those blue colored tiles there, you'll see that self-funded plans that are outside of Active Care with both of those contributions combined still pay more than what an Active Care district pays. A lot of times, though, I will say that employees don't see that. They only see their employee contribution, but they don't see how much the district is actually pumping into their plan to give them that cost savings. And that's a significant factor that I think sometimes employees can be misleading a little bit. This goes back to what Monica was saying about the volatility of the healthcare claims, basically how a catastrophic claim can really impact your district. So $125 per month is what an impact would be on a $1.5 million NICU baby. That's what it'll cost per member per plan on a self-funded plan versus with us, it only costs us 47 cents per month more for that same NICU baby. How do we keep admin costs so low? So we have in-house, this is everything we do here that's listed here is all done in-house. We do our contracting in-house, and we do go out for RFP bids every 6 years, and that's for the medical plan and also for the prescription PBM. And then on the operations side, like Monica said, I am the manager of operations. She is the director of operations. We manage the contracts. We make sure that the contracts are fulfilled from our vendors. We also have our engagement and communications team that will work with you as districts to communicate plan changes, employer premium changes, everything that you need. Our engagement and communications department can help you with that. And then we also have an actuarial department that helps come up with the rates every year, and they work with our leaders to work on those rates for the year. And then we have our analytics team that analyzes data and looks at how we can further save on the Active Care plan. And then our finance team also works in conjunction with all of our teams to make sure we are giving you the best savings possible. And this just goes to illustrate where our 97, if we're spending 97 cents of every dollar going directly to healthcare, this is where we're able to provide with that savings. So zero preventative cost care, TRS virtual health, mental health benefits at zero cost, 24/7 customer service, one-on-one health coaches, weight loss and nutrition programs, and much more. So, and our Blue Cross Blue Shield team will go over that. Just wanted to go over one more slide, and that is the choosing a piece, why we opt to choose PCP. TRS and Blue Cross feels strongly about the value of PCP. And we know that everyone should have one, and it's not required by your plan. And we know in most cases it's not required by most plans, but the PCP is the single best source for knowing and understanding one's health.
Do you want to explain what a PCP is?
Yes.
If anybody's listening on the
Yes,
live
of
stream? Course.
And that is your provider,
Primary care, right?
I'm sorry,
Is it the
a
primary?
preferred provider for the network. And that's just basically your primary care physician. Both of our plans that we offer, the primary and primary plus plans do require a PCP. And so this just helps why this little slide here helps understand why we like to have manage PCP healthcare plans. And it is a cost saver for the plan as well. And then Clayton, can you go over the wellness slides for us?
Thank y'all. Appreciate it.
Sorry, I'm going really fast trying to keep time.
Oh yeah, no, yeah, most definitely. I'll
So if you
probably
have
be
any
the
questions, we'll come at the end.
definitely one that won't need that microphone for you guys. So, but if you do need a little bit of something to explain more, please let me know. My name's Clayton Easom. I am the Senior Lead District Ambassador for the Blue Cross Blue Shield account management team for the TRS account. I am one of 9. I am one of the 9, and I am the one who's senior on the team. My role is to train all of our new hires. It is also to conduct quarterly ongoing training on various topics like sales, empathy, customer service, data analytics, etc., to make sure that we have the best people out in the field. Because in reality, the district ambassador team is here to be the boots on the ground here at Kingsville, here in Region 2, for any questions, to help out with anything from health fairs to open enrollment to sitting with you and talking about your costs and claims. That is what our role is, to get that feedback from you to better the plan for the future, okay? So let's talk about a few of the ongoing things. I know you guys have the costs. I know you guys have the plan breakouts. What I want to talk about today real briefly is the add-ons, the freebies, the things that are included in the plan that we at Blue Cross feel very, very strong about, that we have partnered with TRS on. The first one is going to be everybody is going to have access to 2 different options for telemedicine. This is at no cost to the plan, okay? This comes with joining Active Care. First one, Teladoc. This is going to be things like flus, allergies, things that we consider to be very acute, non-lingering. And then the cost of this is actually going to be $0 for anything mental health, and in between $12 and $30 for medical. I like to joke on this one and call it coverage from the couch. Right now, Teladoc is boosting something around 15-minute callback times, meaning all of your teachers and employees, if they wanted to, they could get in touch with Teladoc during lunchtime, and they would have their prescription waiting for them when they got off work. ReadyMD, difference between these two. ReadyMD is also available to everyone. ReadyMD, though, is going to be a way for you to video in with board-certified physicians. Example I always use is, let's say that you ended up stepping off the curb wrong and you don't know if it is a strain or sprain or what. All you know is that your ankle looks like a balloon. So you're able to actually video conference in at your convenience, and they would be able to assess and see if this is something that, yes, you can just grab some ice, maybe a bandage, or yes, this is something that you would need to go in on, okay? And again, both of these available to all employees and their dependents at no cost to the plan, just at a copay amount to the member using them. Preventive screenings. We cover all preventive screenings at no charge. And when I say no charge, I also mean no copay. So even if you're going to see your primary care physician or you're going to see a specialist, things like that, they would charge you a copay. If you go to your primary care physician to get your preventive screening, we don't charge you anything. One thing that we do want to make sure y'all know is that you guys are using your primary care physician and it's in a setting, a place of service instead of a ER, things like that. But as you can see there, we have lowered several of those recently. Mammograms down to 35, colonoscopies down to 45 years old on that. We're also covering the wellness baby exams, female exams. Really, this is just a small tip of the iceberg that we cover. And we will go over a website to show the extent of that greater in just a minute. And then I think this might be last, not sure. But we also see that the population of this industry is about 65% female. And an even large part of that is in the family planning portion of that. So we have partnered with a company called Ovia. And Ovia is actually an app-based service. And there are 3 different apps in one. The first one's going to be Ovia. This one is going to do tracking cycles, ovulation, and then it also provides information on menopausal support for those that need that. Ovia Pregnancy is going to do for how is the baby's growth, what can I expect, what are body changes going to be, the size of the baby every single week, et cetera, et cetera. And then the last portion, which is the one that I love the best, I have a 3-year-old myself, is the Ovia Parenting. A lot of these apps and these services, they stop the baby the day the baby's born. We actually right now are giving advice to the parents all the way up to age 16. So don't lock them in the closet or anything like that, but it gives actual good advice for the parents on raising the child, which I love. And then our wellness. I know that was a topic that everybody really wanted us to focus on today. We have a dedicated website to all employees and their dependents called Well on Target. Well on Target is your one-stop shop for any and everything wellness. On there, you can find gyms in the area that we do discounts on. You'll see that at the bottom there, that fitness program. You will find self-paced programs for you on various topics, like, as you see, losing weight, dropping your A1C, managing stress, which I know nobody has, better sleep, et cetera, improving your cholesterol. And then some of these, we actually have coaches that will outreach to you on a weekly basis to make sure that you're staying on track and make sure that you're graduating those programs. So it's a great, great resource. There's several things for self-paced. There's several things for coaching. We have all kinds of really fun programs that we're going to go over later as well, like a Walker Tracker program where everybody gets together and joins in and sees how far they can as a team do their steps and things like that, and great prizes, et cetera, et cetera. So we do a really good job of incentivizing everyone for doing things to get and stay healthy. While you're on our Well on Target, and I think I'm getting close to my curtain call here, all of those programs that I just talked about, I said we incentivize you. We incentivize you to do things to get and stay healthy. The biggest and first one there is our Blue Points. So any of those things that I mentioned that talk about completing a program or getting your physical or putting in your A1C numbers and things like that, those you get Blue Points from. Free money. Basically, it's a online portal similar to like Amazon, something like that you would think of. And we have over 1 million different products. And I promise you're not going to be a walking billboard. It doesn't say TRS, it doesn't say Blue Cross on it. They've got everything from gardening to Jenny Craig I saw the other day on there, high-end headphones, video games for the kids. There's over 1 million different products, 100% free. Just for example, $2,500 you get every single year for just entering in your physical. Also, I know that we talked earlier about how large Blue Cross and how large TRS is. Over 400,000 members right now on the TRS plans. Because of that, people want to work with us and give us discounts. And so we turn around and give that to you. And that's what Blue 365 is. It is an online portal that you can sign up for. It is 100% voluntary, but it will send you discounts. We have people that have gone on a $400 discounted cruise on Celebrity from using 365. They had trips to Disneyland on there as well. So, and then last, we see that a lot of times the difference in cost has a lot to do with where you're getting the service done at. Okay, example I always use, the technology for an MRI hasn't changed in about 5 years. So really the only cost difference between having it at facility A and facility B is that fancy coffee machine or how many employees they have there. The actual machine hadn't changed. So you are able to go online. We have what we call our cost estimator and our provider finder, and this is available to everyone. And they can go on and they can look and say right there, mammogram. I want to have a mammogram. Tell me where I can have a mammogram. And it will pull up all the facilities, and then it will show you what the average cost is, and more importantly, what the average reward is. And you can get a monetary stipend for having that at one of our beneficial facilities. And those are your averages there. We automatically put it on a ledger for you, so you don't have to do anything. We automatically put it on a ledger for you, and then you can take that off next time you say you go in to refill a prescription, and they go, this is free. That's because you got your MRI, and we put $107 on your account for you for free. And then it takes that off. Last. So this here, I just really want to talk about this. So I mentioned that I'm a district ambassador, and I have 8 others around me across the entire state. All right. We have one up in the Panhandle. We got a guy down in Terlingua. We've got a couple in Austin, Houston, Beaumont. We have another one in Harlingen. They're actually headed to Harlingen here right after this. So we are all in the area so that we can be available for you. But besides that, we also have a 24/7 dedicated customer service called our personal health guides. These are experts in the field. They have been with Blue Cross for a very long time. This is kind of a promotion for them whenever they get to allowed to be on this. And they're 24/7. I know that that was something that we wanted to talk about, so I'm going to tell you a couple of quick facts on them, and then I will stop. One, I said they're 24/7, based here in Texas, not getting anybody overseas. Two, we have an average call answer time of under 10 seconds. It averages between 6 and 12. Recently, it's been closer to about the 8. So you're not going to be on the phone for an hour like I was with American Airlines today. And then last, they will stay on the phone with you until they solve your problem. The average time for them is 10 minutes. So they're not just trying to get you off the phone. They're genuinely trying to solve your issue and help you out. And because of that, we have a 97% satisfaction rate for anyone who calls in. Okay? I think I've talked enough. No, you're good. But thank y'all very much. And as I said, we'll have questions at the end here and go from there. Thank you.
I know we're getting to finishing time, so I'll be quick. But my name is Nestor Hinojosa, and I am the district ambassador for Regions 126. I am located in the Houston area, but like Clayton said, we're the boots on the ground, so I made the drive down here. So who are we? We are the PBM. We cover over 100 million people, PBM being a pharmacy benefit manager. We provide access to our home delivery service for prescriptions or over 60,000 retail network pharmacies, including down the street. You have H-E-B, CVS, you have Walgreens. All of those are going to be in our network, and you're able to use any of those on these plans. You have simple apps. You have the website. This one gives you information right here on using the pharmacy. You can either use our Express Scripts home delivery, which like I said is free, or go to a local pharmacy and you can do that for the 30 or the 90-day supply, whatever's more convenient for you. Yeah, we have our dedicated line, which is available 24/7. This line is specific to TRS Active Care. Just like on the Blue Cross side, we have some available 24/7. And our website as well is dedicated to this plan. So you can see all of the plan information and everything before you even enroll. Okay. Yeah, that pretty much covers mine. That was very quickly, very easy. And I'll go back to Marissa.
Yeah, so I just wanted to hit on the points here, what we have available for you as a district. So we talked about member servicing. This is district servicing. So like Clayton said, we have our district ambassador, which are boots on the ground, and they help us strategize along with you, the districts, about what you would like to see. They're available to meet with you. They're available to come out to health fairs and let us know of any plan innovations that you're thinking of. That's part of what we offer on Active Care, as well as benefit administrator advocates. And we have a separate company called BSwift that handles our eligibility and enrollment. And they are part of our team as well. And those are the advocates as far as enrollment and eligibility. And then we have personal health guides to help benefit administrators administer employee plans and help guide them on what the member may be looking for. Just wanted to introduce you guys. This is a picture of all the district ambassadors for Blue Cross Blue Shield so that you guys can get familiar with them. And then we want to talk a little bit about next steps and what it would take for you guys to join TRS Active Care. So as you know, Senate Bill 1444 passed in 2021 that established that that a district could participate in TRS Care and they could join Active Care and they could join for 5 years. So this just talks about what the rule is. If you guys are looking to join us for a 9/1 of 2025, you would need to notify us by 12/31 that you want to join TRS Active Care. And that would take a board resolution. We would need that information. And we would need also an intent signed by your board that you all are joining want to join Active Care. And it is a 5-year commitment. You would be staying for 5 years. And that starts as of 9/1. And if you decide, one little thing I wanted to talk to you about, because I know you mentioned also joining in a short plan year, for the January 1st plan year. And this is just bridging. We do offer what's called a transitional plan year, where you can join on a January 1st. You would be rated individually as a district, We had had a district join us recently, actually, with a 9-1 plan year, and we transitioned them over from a 1-1 to a 9-1 plan year. So we bridged that gap. That is doable if you're looking at doing that and doing a 1-1 start date with Active Care. We would need to know about it by July 5th of next year. So that just gives you a little timeline. So that way you guys know. I know I went through that really fast. So that was the end of our presentation. Do you guys have any questions or concerns? Yes.
So you do have HMO plans and PPO plans?
So our plans are considered PCP driven plans. They're not, yeah. So that we do have a PCP, 2 PCP driven plans and an HD plan.
So that's why I didn't hear HMO.
Mm-hmm. We have an HMO available in Region 1, but not in Region 2, a full HMO.
Why is
It just hasn't come up for this region. They just didn't, we go out to bid for HMO plans and they didn't bid for this region, only in Region 1 and then also in the Panhandle.
I've got several. Go ahead.
because Texas is such a big state and you have a lot of districts, have the claims been real expensive to where we've seen premiums go up, let's say, in the last 5 years?
I will tell you that in last year, on average, our premiums averaged about 10% increase over all 20 districts.
Okay, y'all are like Big Umbrella, and Blue Cross Blue Shield is a provider.
Correct. They're our managing company. Yes, they
All right.
manage our plan, administer our plan.
And you go out every 6 years for bids.
Mhm.
So how long is their contract for? In other words, in 6 years, is it possible some other provider could come along other than you?
Absolutely. Yeah. So it is possible in 6 years that somebody new would come in, and it is actually through the competitive bid process through RFP. So another medical provider or pharmacy benefit manager comes in and their bid is more competitive, we will go with that. Now, I will say we do not sacrifice customer service. We are looking for the best quality across the board. You know, who's going to give us the best rate without sacrificing the quality of administering the plan.
Who governs TRS?
We're governed by our board of trustees.
Okay.
Yes. Mhm.
Um,
And they are all appointed by the governor.
In here, it talked about, I think it was on the wellness, it listed a couple of different, I'm assuming there are options that the, hang on, page 27. Active care, primary, active care, primary, I mean, there are levels that the individual can choose as to.
Right. We offer 3 different plans:
Okay.
the Primary Plus, Primary Plan, and HD Plan, high deductible plan.
Okay.
Mhm.
You talked about different rates for different regions,
Correct.
but are the services the same? Now, we just had an HMO difference in some regions that maybe we don't have here, but overall services are pretty much the same.
The active care plans across all regions are all the same. The only caveat are those fully insured HMO plans that are offered in some regions.
Gotcha. All right, and Dr. Pitts, I'm gonna need you to help me with this one. On page 10. Page 10 talks about the rates and kind of divides it up into the employer's part, the employee's part, and the out-of-pocket. There is a state minimum that a district must pay. Is that correct?
Yes.
Does anybody know what that is?
225, and it's 75 from the state and 150 district.
Okay. And that is per employee or per participant?
Per employee.
Okay, so if we've got 450 employees, but only
316. Let's say that we have 316 that are on a plan right now.
we pay for the 316, or do we pay for the whole number?
Only the ones that are participating in the
Okay.
plan.
All right. And the actual dollars that we're paying right now is
Are you talking per individual or
our,
total
our,
cost of the
our
plan?
contribution at this point is substantially above this 225.
Yes, so We put in $479 per employee per month, not per participant, not per employee, but for all 479 times
Because
450.
we're funding a pool.
We're funding a pool, and the 479 for each employee will not fund our plan right now.
Okay. I think that's all I have for now.
And just so you know, our lowest cost plan on active care primary employee only is $481 right now in your region.
I have a question, Marissa. So we have, I guess we have an area where it's hard to get into doctors sometimes. Sometimes there's a wait, a couple of weeks, maybe even a month. What's the alternate plan if you cannot get into your PCP?
You can use our virtual services if you cannot get into your PCP, but we also have our Blue Cross Blue Shield team, those personal health guides, can make a phone call out to your medical providers. And also, if there's a provider that's not in network, they can reach out to them and try to get them in network as well.
It's a very easy process, but at the same time, if you are having a very, very difficult time getting into somebody, you do have also the options of the UC. You do not have to have referrals for a UC if that's something that you want to. For those on there, urgent care.
Urgent care.
Do not have referrals or anything like that to go to one of those. And then we do have a very easy process for, let's say, for example, this is something I do a lot. Let's say that you have somebody that you and your child see here in Kingsville a lot, but once or twice a year, you go into Corpus for a full-on checkup and things like that. We do give you the ability to change those at any time and go back and forth. So if you wanted to have somebody here at Kingsville for every day, you are able to do that, and then you're able to change it and then change it back. So you are able to do that. If there is, though, issues in regards to exactly what Marissa said, our personal health guides have been in the industry long enough. They know what a gatekeeper is. They know that there's probably one person that's sitting behind that desk doing 15 different things. They can help and assist with getting you in.
And just so you know, we checked urgent cares, and Access Urgent Care here in Kingsville is part of the Blue Cross Blue Shield network. And then the hospital is Crisis is also in network. And we have five other urgent facilities within the 30-mile radius, 3 hospitals, 98 PCPs, and 40 pediatrics available.
I just want to clarify what you said earlier, that the lowest cost plan was 481. That 481 is total. A district is going to be contributing part of that,
Correct.
Whatever the district decides, and then the employee will be paying whatever else.
Right,
Okay.
correct.
That is before contribution, before your contribution.
Before the
or state minimum.
Okay.
correct.
Any other questions?
I have some, does this insurance TRS, are there gaps in insurance? In other words, in my situation, my prescriptions, I'll pay for a certain drug, and all of a sudden that drug cost increases because I'm caught in a gap.
No,
The employees won't get involved in anything.
I've never heard of a gap before.
I think you're talking about the Medicare donut hole. Yeah, that's on Medicare.
That's what I
This-
think.
Yeah. That's not,
That's
yeah,
not.
does not apply here.
Okay. My other question is what is the plan year?
September 1st through August 31st.
Okay, and September 1st, before September 1st, will you guys come, or will TRS come down and meet with the employees?
Mhm.
Like-
So what we did, for example, we just brought on, so backtracking, we had 114 districts leave during Senate Bill, the first year that Senate Bill 1444 came about, just so you get an idea. First year, 114. Second year, 14. This year, we only had 4. We brought in 10 districts this year, which is the most Active Care has ever brought in one summer. And we went out to every single district. We met with them. We met with their board. We met with their employees. We went to their health fairs. We sent out pre-made communication so that the districts could share that movement that they were moving to Active Care. We shared that with them so that you guys could basically just fill in the blanks and send it out to your employees, and you didn't have to come up with those
In other words, you do
communications.
that just the first time that we get with TRS, then the other years, the school district will be responsible?
No. We
Right.
still send out those communications to you and the members as well. We communicate everything. I mean, but we probably fill in their email boxes way too much, and their mailboxes for that matter.
But you
My-
send
my
out,
team,
Yes.
I'm sorry, I didn't mean to interrupt.
you send out the materials, you don't necessarily come?
No, we can come.
Okay.
And we
That's
send
what
out
I
our
was gonna
DA
say.
team.
Yeah, that's what I was gonna say. My team, 9 of us, we did over 1,100 events between mid-July and the end of August. We were on the
Everywhere.
ground. I personally did 3,500 miles in a car. I was at almost every single region, and we had our 8 others that were out there in the field almost every single day, Monday through Friday. Now, in regards to a new district, we do earlier because we want them. So let's say, for example, everyone that came on this last one that Marissa just said, they came on 9/1, it just recently came on. We were in touch with them with materials and everything of what's going to change, transfer of care, things like that in early May. Got everyone signed up and everything like that. For everyone else, multiple years afterwards, it can start. I have districts that ask me to come and present to the staff before they leave for the summer. The joke I always hear from benefits people, I don't get them before they leave for summer, I ain't getting them until they come back. And so we have people that will have us out to do benefit presentations just like this, a little bit more in depth on not the admin part of it, but of our programs and things like that. And then we also, as I said, ours started in the El Paso area probably mid-July, and we had it all the way up until enrollment was over, which was August 16th. Please.
My concern is employees, if they can sit down with someone and explain their situation.
Yes.
I have kids.
Yes.
I have pre-existing condition, and that way they can be led to what, helps you. Yes.
Yeah, 100%.
That's what.
We have days of dedication when we will be here in wherever you would like. We can go to multiple
Member
campuses,
sessions. Yeah.
whatever that you would like. Also, as I said, I'm not 100% familiar, but we also work very closely with your TPA. So the company that you guys would use for your ancillaries, they would be here with us as well, helping everybody get into the system, helping everybody get signed up, making sure that all of their information is correct so they get their ID card. So far, they've been on it for 6 years, and we've gotten ID cards every single year. And so making sure everybody's all set up and everything like that. So
I think that's very important.
Oh, absolutely.
And that's our key
100%.
role. Please, ma'am.
Okay, I come from a district where we do have TRS.
Yes, ma'am.
And no one has ever come out to explain to us anything.
It's whether or not your district asks
So
us
that's
to
what
come
I'm
out.
saying, it's like, do y'all really come out?
It's based on your district. Some
'Cause, I mean,
districts,
Nobody
No.
has ever explained to us any of this.
yeah,
I
some
would be more than
districts.
happy to send you, as I said, it was around 1,100 events that we did. And I can break that out for you even more to show where we were in Region 2. But yes, I personally, in my area, which is more the Panhandle, I personally did about 125.
It all depends on the districts having
Yeah.
us out. I mean, if they don't let us know that they want participation from us, we can't come out. So we do that via our district ambassador team. We have them reach out to the districts. Hey, do you need presentations this year? What do you need? And so if they sign up, then we'll be happy to come out and just do
I
that
don't
for you.
think we've ever had a presentation.
Well, but we
To be
make the
truthful.
onus isn't just on the district.
Yeah.
I mean, so there are various monthly emails. We really had to be quick, so we didn't want, we dropped a slide, but there's pulse emails that we send out. There's participant, so employee emails we send out, administrative emails that we send out, and then we have a wellness kit that we send out every single month to everybody. Voluntary, it's not gonna spam you. But in that, they're ones that are led by us, and we put in, hey, we're already starting to book out for annual enrollment. Would you like for us to come out? Please go ahead and do it early, et cetera, et cetera. This is what we typically will do. And then we also like to come back in the spring when everybody's forgotten everything and do a kind of refresher with health fairs and really not focus on here's what your deductible is, because you already know that. But when was the last time you got your physical? When was the last time that you got your mammogram? When was the last time you got this and that? So we're constantly trying to, as I said, we are as engaged as you would like for us to be.
And I'll go circle back a couple of more points on that. In addition, TRS, us, we host a quarterly Active Care Connect call, and that is where we, as the leaders of TRS Health, our chief healthcare officer meets with the district leaderships. We send that out in email, and we actually do have them virtual now. We used to actually have them in person, but we do them virtually so we can actually have more of you attend those. And it is all about what is top of mind. What do you need? Do you need folks to come out and do presentations? Do you need more of our district ambassadors out there with you? So that is something in addition that we do in addition to what Clayton and Marisa have both mentioned. Mr. Pettis, I wanted to circle back on what something you said earlier, because it really struck with me that you're really concerned about the employees getting the information that they need. I wanted to circle back and reiterate what we said in here, what both Clayton and Nestor said. The individuals, those personal health guys, said work at Blue Cross Blue Shield and Express Scripts, they are fully dedicated to TRS Active Care. These are the only accounts that they work on. They are vetted by us. They are monitored by us. They're available 24/7. So in the event that one of the employees cannot meet, 8 to 5, come out to one of these health fairs, they're there 24/7. That's why we have that. We know teachers, the last thing they want to do when they get out of school for the day is sit and talk about this. Maybe they're going to do it on a Saturday morning. That's why we are there to answer those questions about those benefits. Okay. And one last point I wanted to say, because Marisa mentioned this earlier, was those school districts who chose to leave after Senate Bill 1444 passed. I will tell you, within the year of those 140 that left, most of them were knocking on our door because they wanted to come back. Unfortunately, because of Senate Bill 1444, as Marisa mentioned, once a school district leaves, they have to be out for 5 full years. So we had to communicate that tough message. You have to wait 5 years. And the reason they wanted to come back was because what they signed on a dotted line for on another plan did not really work out for them. And they got that experience that the premiums were a lot more. It was not that experience, and it was a lot more of a burden on them to manage those plans.
So they left within the 5 years?
They left at the beginning when Senate Bill 1444 was passed. And once you sign and tell us you're leaving, you have to stay out for 5 complete years.
So when they signed, they stayed with you all 5 years and then they decided not to?
No, so these were districts that were already
with
in.
us, yes.
So the previous rule was that once you were in active care, there was no way out.
Yes.
And then Senate Bill 1444 changed that.
How long has Blue Cross Blue Shield been the provider?
2020. Yep,
So
during the
this is
pandemic.
This is our plan year 4.
4.
Who was it before?
Aetna.
Okay.
And then it was Blue Cross before that.
Before that.
Which they go back.
Yeah.
My last question, I promise my last question.
Of course.
Does it require a benefit administrator at the district level? Do we have to have a person at the district level who kind of is the benefit administrator?
I would say yes.
Yeah.
You would still need a benefit administrator, and that's for administratively at your district to be able to handle those enrollment forms and take changes for the individual, unless you work out some other kind of plan with your third party administrator where they do that for you. We have some school districts that do that, or they say the TPA is the administrator for eligibility and enrollment, and they handle everything without having a BA, but you would need to have either or.
But this is primarily for enrollment?
Yes, for just enrollment,
Okay.
yes.
Well, I mean, it can be anything. New hire comes on, somebody gets married,
But
somebody.
like, they don't submit any kind of claim forms or?
No,
anything?
it's just
nothing
enrollment and
I handle
eligibility.
every bit of that. This is only administrative things we're
Right.
talking about. But yeah, somebody gets married, somebody's dependent turns 26 and needs
New
to
baby,
be
all of
dropped,
that,
new
yeah.
baby that needs to be added. I mean, there's constantly some form of
Some
something
change.
that might need to be done.
Mhm.
Quick question, do you have rebates for pharmacy drugs?
Sir, do you want to take that?
Okay, I can also answer that as well too.
Yeah.
So this is kind of the difference between fully funded and self-funded. Self-funded, you manage all parts of the plan. You are responsible for all payments, all claims, for admin costs, for stop loss, for claims, And at the same time, you get rebates from your pharmacies that usually are, I guess, a deduction from the amount that you have to pay in claims. So, but when you go to a fully funded plan, this is how much you're going to pay. You don't get any rebates or anything like that. This is how much you're going to pay. It doesn't matter what your claims are. If your claims are $2 million more than what you expect, then you still pay exactly what the premiums are. Whereas with a self-funded plan, you get to benefit from things like rebates, but at the same time, you're on the hook for everything else that you have to do. So
Right, we administrate all that for you, so you don't have to do it, and we take care of that. We're not going to come back and charge you because we didn't get an expected rebate or because your premiums were higher later on down the road. No. Whatever your premium is for the year and the employees that you have signed up, that's what we're going to charge you for. Any other questions?
Any other questions? All right. Thank y'all very
Thank
much.
you.
Appreciate your time.
Did you need us to stick around for additional questions?
I think in case, stick around in case we have questions later for them or not.
We'll leave a couple of our cards.
Okay.
Thank you so much.
Thank you.
Yeah. All that safe travels.
Thank you.
Did y'all want to take a quick recess before Edna presents, or are you ready for them to start? Okay. So here for Edna, we have John Bierwagen and Olga Robledo to present for Edna. And Edna has been our provider for about 5 years now. I think this might be the 6th year, is that?
Like 7,
Oh,
actually.
7? I'm a year behind.
Time flies, right?
Okay, I think we're ready.
Perfect. Well, good evening, board president, superintendent. Thank y'all so much for having us. Y'all are going to be insurance experts by the end of this evening. But we're going to be brief. You certainly know us. We know you. We want to spend a little bit of time. As you heard Dr. Pitts say, my name is John Herwagen. I serve as Vice President of Sales and Client Management for Aetna's Public Sector and Labor Division in Texas. And I'm with Olga Robledo. Olga is your dedicated account executive, so she leads the team that supports you and your staff on a day-to-day basis. And I'll just start by saying, again, we appreciate the opportunity to be here. The fact that you've carved out time today and you've dedicated this workshop to your insurance plans really signifies the importance of the decisions that you're going to make, not only for your district and for your budget, but for your employees and their families. And so we recognize those decisions and what you're weighing, the pros and cons, and certainly appreciate being here. We've also enjoyed the 7 years that we've worked with the district together. We were fortunate to be able to extend our relationship when you last went out to bid January of 2023, and we're fortunate to be successful to continue that relationship. And I would say our primary role today is to support you, the board, and staff with questions as you think about your decisions that you make, especially as you think about the impact of relinquishing control of your health plan for the next 5 years and the funding and the administration of that. So we really want to just support you in that. I do want to spend a minute or two just talking about Aetna, who we are, and then our relationship, kind of how that self-insured plan is structured, and then want to leave plenty of time for questions. Let's see if I can advance. So Aetna, as a company, is 170 years old. While we actually were the company that wrote the first Medicare check, we have a long history. And Olga and I, again, get to work every day with our tax-supported entities in Texas. But for the past 6 years, we've been a part of CVS Health, the broader CVS organization. And that was a partnership where we came together with CVS and we took the best of what CVS Caremark offers their plan participants in the market and the best of what Aetna offers, and really combined two companies into a singular mission to transform healthcare, make it more simple, more affordable, more engaging, and more local. And we do that in a couple of different ways. We do that through our local footprint. So think about the CVS stores and creating different experiences in those CVS stores for Aetna participants. We do that through innovation. It's innovation in our network strategies and innovation in clinical programs that outreach and support your members throughout their healthcare journeys. And then we do that with data and information. So if you think about every time one of your employees visits a doctor, a hospital, picks up a prescription, the amount of information comes with that visit is substantial. And we take that information and use that so that we can be proactive to outreach and support your employees and their family members. I say that, and as an example, our clinical team, my nurses and case managers, can take all of the data associated with our members and look at that data, and with about a 95% accuracy, predict which of your employees are going to be inpatient in the hospital or the ER in the next 12 to 18 months. Then it becomes our job to reach out, engage, and support your employees to help improve their health, close gaps in care, and try to curtail or keep them out of the hospital. And so that's been a big focus of ours as a company as we go through those clinical outreaches and leveraging that data. We're also very focused in being local. If you take a stance that you're going to transform healthcare, you have to do that at the local level. So we do that a couple different ways. We do that with a program called Project Health, where we bring out the CVS Health mobile bus and deliver free healthcare to underserved in the communities. We've done about 2,000 of those to date in the state of Texas. We address food insecurity with community partners, and then we address affordable housing. We're one of the biggest contributors in healthcare to addressing the affordable housing crisis. And we've contributed a little over $200 million in the state of Texas alone to address affordable housing. And to date, if you break that out, that's a little over $1 million across Quiberg and Nueces counties. If you think about the 234 counties in Texas. So really focused on how can we make meaningful impact, because you can't just address the health plan, you've got to address the whole person. So, but if we think about our relationship together, and I know you heard a little bit about this as we talked about the differences of fully funded and self-insured. You heard a little bit about this from the TRS team. You're in a self-insured arrangement. So what you hire us to do through RFP is administer your health plan. So we are responsible for establishing the network arrangements, the contracts of doctors and providers. That's one of the largest contributors to your cost piece, right? Because if you think about the largest component to your health plan is your claims, which you're responsible for, that's people utilizing doctors and hospitals. When I look at my network compared to competitor networks in the market, and this was also done in your RFP process, we align and are essentially at par with the other payers or providers in the marketplace, meaning there's not a big cost difference in the networks between us and our competitors. This is a market where we keep very competitive contracts. We have very strong hospital arrangements. So you hire us to manage the networks. You hire us to do customer service, take care of your employees, run your clinical programs. So that's like the oncology program, the diabetes program we have, our maternity management program that we provide your employees, all of that outreach and engagement. We run your wellness programs. So things like on-site biometric screenings, the ability to have digital coaching and go through health journeys online, the discount programs, a lot of what you heard in the earlier presentation, we do that as your administrator. We have those reporting and analytics components. So really, and then we do claims processing. That's the biggest piece as well. And that's what you hire us to do as your administrator. The rest of what contributes to your budget is the claims themselves. When you think about a fully insured plan, again, you're relinquishing the ebbs and flows of that plan, But when you have good years, like you had in 2023, where your trend was at negative 6%, you don't see the financial benefit of that. Conversely, if you have tough years, you're protected or insulated. It's really a component of where on the risk spectrum you as a board and you as an organization want to sit. The biggest takeaway I would share is that when you think about a big transition, and this takes place for any of our school districts that are outside of the state plan, as they think about different payers or administrators, or in a scenario like this, you have maximum control as a self-insured plan. So if you wanted your Aetna offering to look exactly like TRS, you could do that. And we could work the financial math to determine if you made your plans, if you deteriorated your plans to match the benefits that are offered in TRS, because your plans have a more rich benefit structure, then we can support that. You have every ability to pull the levers and controls. But conversely, you hold some of the financial risk that's associated with that. So I just want to level set on kind of how your arrangement is today, that we have all of those abilities to pull those levers and control. You know, really the big fundamental difference in our mind is you're leveraging economies of scale. They talked about big membership on the administrative components of the health plan.
And if I can chime in,
Sure.
John, another thing that differentiates your plans from TRS's is that you don't have a PCP requirement where your folks are having to ask for referrals to go to a specialist.
Yep.
They can walk into a specialist without a referral. The only time that would occur is if the specialists themselves, the doctors, because they get so full, would require it. And that's completely away from the insurance company.
And we have plans where we can do that. We can structure the PCP requirement. We have those similar plans too. The majority of our school districts in Texas opt away from that structure to allow freedom of choice and open access.
Mr. President, is there any benefit requiring a PCP?
You don't have one. You don't have one today. We can structure the plan to support that. Again,
Does that save the school district some money having that requirement? Why would they have a requirement like?
where do you see value in that?
Yes.
So there is, if you look at data, and I'm kind of a data nerd, if you look at the data, as you increase the number of people that engage with primary care doctors, you see a direct decrease in emergency rooms. The state of Texas, the stat is about 40% of Texans do not have a primary care physician. And so we have some programs and services where we've implemented even virtual primary care. You can establish a relationship with the doctor virtually, but you certainly can put that in place.
Which is a great offering for y'all, since you're in a rural area, and it's limited with the number of primary cares locally, being able for your employees to, communicate with a virtual primary care is very, very key.
So you mentioned that 40% or so do not have a PCP. Let's say I did not have a PCP, but I gotta go and see a specialist. I could do that, absolutely. Our people can do that.
Take it a step further. If we know that you don't have a PCP and you go to an urgent care, you go to an emergency room, you go directly to a specialist, we're going to make outreach to you to make you aware that a PCP benefit is important, or where were locations that were more cost effective for you. Because we can all recognize the most expensive double doors in healthcare is an emergency. And it has a purpose, but a lot of times that's where people use as their primary care.
Which is a great thing about our care management program is you have Aetna One Flex. So if we see that you have someone who doesn't have a PCP, we'll reach out to them.
Mm-hmm.
We also are interconnected. So if somebody goes to the pharmacy and let's say they haven't seen their endocrinologist, the pharmacist can look into the system and remind them, hey, you might want to get on the phone and make an appointment with your endocrinologist, because we're all interconnected.
Yeah, Aetna invested and CVS invested $200 million into what's called electronic health records. So when you go see your doctor and they turn and they're on their computer, and then they talk to you for a second, they're using their electronic health records, and we can connect with 9 out of 10 doctors. And what that connection means is we can push information to them. So if your doctor is going to prescribe you something, they can see which prescriptions are on your formulary and 5 cost-effective alternatives. And it can be a click of a button for them to choose. So we share data with 88% or so of the providers across the United States.
One of the concerns about having a PCP is that here in Kingsville, Morales and Rodriguez, they're one of the main doctors. You can't get in. So doing that, it's hard to go, and you have to, we allow our employees to go to Castañeda. So if you have a primary care physician requirement, that's gonna make that difficult. And so like I needed to see an orthopedic, and there's one in Corpus that just allows you to go in because we don't have a PCP requirement on the plan. Had I needed that, it would have been a week or 2 weeks before I would have been seen, because I would have had to go see Rodriguez, which is a week or 2 weeks out. And then by the time I got into the orthopedic, then it would have been around their schedule. You're talking about a month later when I've already been 3 weeks in the boot. So that's the only concern that I have, is that we already have an issue. We've addressed that that's why we entered with Phil to be able to see Castañeda or Access Care. That's the only piece that having that PCP, we are literally controlling our employees as to what doctors they can see. A lot of times they see different ones because it's whoever they're going to be able to get into.
What about WellMed? Is that considered a PCP?
So WellMed is Medicare
Yeah.
provider, so you don't have Medicare, because we do have Medicare.
I'm only 65.
I can help you with that.
I don't know
It's about the gap, okay.
That's going away. The donut hole's going away. Good news. It's
Oh, is
going
it
away.
really? Oh, man.
If you didn't need a PCP, couldn't you just go straight to the?
We don't require it. So that gave me the ability to
This
go.
insurance, right? This insurance.
Right, this current insurance.
Allows that.
I was able to, and I went to the emergency one day, and then the next day, I went to the orthopedic, who allowed me to just go in, and I didn't need a referral. You're gonna find some that do. And it's not that the insurance is requiring it, it's the doctors get overbooked, but now with the orthopedics, there's so many in Corpus, I was able to go in, and they treated me
Without
without a PCP. So there could be a 3 to 4 week delay with the PCP. That is, in my personal experience, that's gonna hold the employee back. We're literally controlling, the timeline that the employee's been able to see. So yes, it might be a beneficial on the flip side, but not to the employee.
But that doesn't always occur. It's not, because I know my son has the same insurance, but with the county. And he was able to get in right away with Rodriguez and with the orthopedic, like within 2 weeks, not even 2
Well,
weeks.
but that's what I'm
he went to
saying.
see
There is a
Rodriguez,
delay though.
Yeah,
If-
but it wasn't anything like a month or anything. He
Yeah.
was able to see him like right away, and it wasn't an emergency.
But right now, the the care we have.
That's right, to the
It isn't
conversion.
even a question. It's like the employees can just go straight to their.
Right.
specialist.
And we've been able to work with, like back in 2020, Castañeda approached us, and Gulf Coast Imaging approached us, and we got Gulf Coast Imaging in network so that they were local. Castañeda, when your folks go see them, it's only a primary care copay that they're paying, unless they have a high deductible health plan, right?
I had a question. I don't know if you all caught.
TRS Active Care talking about their 10% increase. So after 5 years would be 50%. Do you see any costs that are going up with you guys?
So medical trend runs, in Texas anywhere from 7 to 8%. Right? That's inflationary trend of healthcare. That's there. I would say, and I think you could survey peer districts. Often what we see other districts do is kind of, despite your claims experience, pass a nominal increase to your claim, so that the good years create reserves, and you're softening the blow of the tough years. Because any health plan, TRS, any health plan, your experience is cyclical. You normally see 1 out of every 4 to 5 years is pretty rough, and then it starts to table off or rebound. And then with school districts, we see predictability in your claims. The summer months are always where your spike is. But I would say most health plans are passing along an increase, or you're increasing your total rate. And so I can't speak for TRS, but I think, it's public information what they do every year and kind of continue to do. And I'm sure some of that is just prudent plan management. The difference is you control that decision for TRS, for your Aetna plan. You relinquish control of what the overall funding rates become for TRS. But again, that's a component of the risk spectrum that you're thinking about.
And one of the things that they mentioned is preventive care being covered 100%. I just want to be clear that that is required by the law to be covered at 100% for anybody. So it's not something that you have a choice to implement.
It exists today.
It exists today. It's through the ACA. And so one of the things that I make sure we do, and by the way, I'm a former school district risk manager, so I did benefits down in the valley. I live in the valley. Now I do. So I used to live, I've lived in the valley, lived in the Boston area, now I'm back in the valley. My husband's a coach, so I'm very in tune with school districts. And, what you all have here with Aetna is you have a dedicated public and labor team. I meet with Dr. Pitts and Sandy on a monthly basis to discuss anything that we see as a concern. Plus, they have the account manager that is there to assist with them. And then they have a dedicated, we call it a PSL, but we have a lot of acronyms. I'm blank.
It's a dedicated person that sits
Plan
in our
sponsor liaison.
claims and call center. So when you get escalated issues, you have kind of a direct contact into the customer service team. Dedicated team.
I felt a little intimidated by TRS. Tell you why. We had TRS, the insurance, we had Blue Cross, and then we had another guy over here. I just want to be a one-stop place. I want it as easy as we can for our teachers and our administration. Right. So, and this is what I sort of felt that way. And I don't want our people to be worried about where do I go here, where do I go there, where do I go there. I don't know.
Insurance is complicated. It really is. It's hard. We make ourselves available. Sandy calls me after hours. Dr. Pitts calls me at 4:59 p.m. on a Friday, and I'm there. They've got my cell number, and I'm there to answer any of their calls. And then we've got, our call-in center is a concierge team that can do more transfers, to other vendors that you may have. Let's say, it's not an Aetna vendor, but they're calling about dental thinking it's with us. And we can say, well, we can connect you over to somebody else that may not even be associated.
And I'm glad you all are here because I had a concern. I don't know how it happened or why it happened or what happened, but we had one of our administrators, our teachers, get cut from coverage all of a sudden. Mm-hmm. Don't know why they're calling. What happened? I don't know. Okay, so we need to make sure that those interruptions, I don't know what happened. I know it's not because they didn't pay. Right. I know they were paying the premiums or whatever it is.
Yeah.
But that's just something that we can had that family not pre-register their son for a surgery or procedure, they would not have known. And she has some, I think maybe some possibly pre-existing conditions that we got to be careful with because we're dealing with people's lives. When it comes to insurance, at least. I don't know. I'm sorry.
No, it's a great thing. And just real quick, so as a self-insured health plan, you control eligibility. So if that happened, it happens from time to time. Let's say somebody changed an address and a digit got left off, or something in a file exchange for eligibility that comes back and forth. it can happen. And we've got a person that's there to kind of live person to fix that. But let's say it happened on a Friday. When they go in for
It
care.
did, and it was after hours, and Sandy called me. and
I
we
did. So
within
it
5
was,
minutes.
it was a key entry, just exactly as explained. And I give out my cell number to everybody. Everybody knows you can call me at midnight, email me, and I'm gonna respond to you. But I did get the call. I did explain. I called Olga. It was on a Friday. She was walking out the door to a meeting. She stopped what she was doing, and that was internal. It was an internal error that happened that was fixed immediately. But because feeds go through the system, I called Olga and she got on it right away, all the way around. And then I called Andy because it's a database that sends out feeds, meaning to all the carriers. And so we personally worked on it, but I worked with her on the evening, on the weekend, the next morning, on the next business day. Dr. Pitts and I, we were driving to a meeting and he was on the line with me and I reassured her. I said, look, it's payroll deducted. The district has the liability. It was an error. I reassured her, if not 15 times. And I told her, I understand that it's critical, but you're being taken care of.
So let me ask you something, Ms. Glenn, now that we're talking. Would TRS have done that?
No. I wouldn't have,
Okay,
well,
I'm gonna interrupt there.
yeah, I'm not
We-
sure.
We do not know right now. We have been,
But it's okay, you don't have to
Yeah.
explain that.
But I'm not gonna have somebody's
Sandy
personal,
already is.
I'm not gonna have somebody's personal cell, and I'm not saying that that's a requirement.
No, I know that.
But what I'm saying, what we currently offer
I know
right
that.
now is that, and I know.
So we're happy with your services.
Yes.
Okay, we're happy with your services. What can you all do to help us afford to continue this? Because my biggest fear, I think, is, let's say we do get that neonatal birth, and it's gonna cost the district over $1 million or something. What can you do to help us keep you all, to
So you heard,
help us afford it?
you heard the past presentation talk about stop loss insurance.
Right.
So what that is you pay a premium to Aetna and we hold the risk for any claimant above $175,000. So if you get $1.5 million neonatal claimant, and in today's world, that could be cheap in that
Yeah.
regard, we cover the expense above $175,000. And because you have our stop loss, it's an immediate change of checkbook. So it means what funds out of your claims expense is up to $175,000, and then we take on the remaining liability. And so you pay a premium for that, and we work with your team on where you want to set that level. Is it 175? Is it 200,000? Where do we think your claims have been trending? How many times do you have claimants that
Bill,
exceed
that's
that
what you help
threshold?
us with, right? That's what you help us with?
Yeah. So Bill helps the evaluation of
What
do
is
you
that?
manage that?
What is that premium amount? that
On
we
which
pay?
one, Brian?
Okay, so we are contributing the 471. The stop loss premium is separate?
No. So oh, go ahead.
I can answer that. So we, every month we pay Aetna an admin cost and we also pay Aetna a stop loss cost so that they can pay the carrier for the stop loss. So now your question was what again, Mr. Kufal?
Well, what I'm trying to get with both of these, because in a perfect world, I'm with you guys. I get it.
Mhm.
And I think our employees love the flexibility that we have. This is in a perfect world and we're going broke.
Yeah.
And if we've got the first 175, what are our reserves right now?
Right now, so we had $500,000 in reserves,
Okay, so that's 5 claims.
But we lost 200,000 this year, so we're only going to have 300,000 moving forward as
Okay,
of
so
September
2
1.
employees up to 175, and we're done. Our reserves are gone. And what do we do then? Because our other reserves, that's our health reserves, and our other reserves are
What we
gone
have to
too.
do is we have to contribute more from the general fund. We are responsible for those claims.
And
that's-
employee contributions, because it's so rich, the plan's so rich, and we haven't increased in years, so.
And Ms. Beltran, I know that, and you know that, but our employees think they're getting ripped off.
Yeah.
Every employee in the United States thinks that they're getting ripped off. And ours don't understand how rich our plan is. We're paying $471 per month when all we're required to pay is $175. And it's breaking us.
Regardless of whether we stay with Aetna or whether, well, let me put it this way, whether we stay self-insured or whether we go fully insured, we're gonna have to increase premiums.
No, I-
Either way, we're gonna have to increase premiums.
I get that, but if her lowest price was $451 or $481 or whatever, and we're contributing 400 and whatever. it is.
79
Okay, so
for all employees.
it's $4 for that person that chooses that to do that. The other thing is for us moving forward is every year we sit here and have to go through this and try to figure it out when we should be in the education business, not the insurance business. And I respect the experts, I do, but you know, there's something real attractive to saying, let the insurance experts handle this, and all we do is have the payroll deduction once a year. And we don't have to worry about the reserves, and we don't have to worry about the rest of that.
So if you think of self-insurance, it's like a bucket, right? So everything the district puts in, everything your employees pay as premium, that pays for admin fees, for claims, for stop loss coverage, okay? And what you need to take into consideration is your plan design. You have a very rich plan design. If you go to TRS, it's not as robust as what you have today. Now, we can make those changes and mirror what the benefits are, and that would make a change in what the employee is. But normally, a school district should see an incremental increase every year, whether it come from the school district side or the employee side, because of
The cost of insurance.
right,
Right.
inflation,
Right.
whatever it is. So it's hard, right? 'Cause I get it. You're giving them an increase. You're giving them
And the
and
hardest
you're
part
taking
about
away
it is that because we have the control, and they understand that. They don't understand that we've got the risk. We've got the control. We're bearing all this risk. And so any change that gets made, we're the bad guys.
Yeah, it's a tough,
it is tough.
it's a
Like
tough
when- Like when
position.
there was like a Christmas bond and an Aetna thing going on, I mean, it was as if it was our fault. It had nothing to do with us, you know? Things like that do come up.
And those things transpire. All of us carriers, and I can't, speak for our competitors, but it's commonplace that every few years you're renegotiating hospital contracts, and there are times, and I think every carrier probably has one in the news right now, where in different geographies of Texas, they're in an impasse because of what's being asked versus what's being willing to be given, and that is a tough position. I don't know that would change, but to your point, perhaps maybe the optics of who's responsible might change. I think the biggest thing that you're faced with is the cost shifting aspect, because again, if we were to put the exact same plan design in, that's what you're doing, right? You're cost shifting. Claims are claims. They're going to exist. There's some predictability to those. You're cost shifting financial responsibility differently between you and the district. That's what you'd be doing in a different funding arrangement. That's what you'd be doing if you pulled any levers in your self-insured plan as you're cost shifting. And then, we can certainly lean into the clinical programs and the wellness to try to curtail or mitigate those that really drive a large portion of your budget.
And I don't want to be ludicrous about this, but let's say we had 360 employees sign up for coverage. We're technically on the hook for $175,000 for each one of those. Correct? I mean, it's not going to happen. Hopefully, all of them are not going to do that, but we could potentially be on the hook for $175,000 apiece.
That's correct. That, like you said, it's not going to happen. But so there's individual stop loss, how much we are on the hook for our plan for individuals, and then there's also aggregate stop loss as well too. So aggregate stop loss, it kicks in after we go over a certain amount. This year it was about 4.1 million. We had spent, we were at about 300. We'll go over the financials, I guess, in a minute. But you're responsible for, I guess, for sure the individual stop loss. But then again, you also pay for two things. Again, they take over whenever something goes over 175,000. But we're looking at probably increasing the individual stop loss for next year, and then the aggregate stop loss if all our claims, like let's say that they didn't go over 175,000 for every individual, but everybody was at 170,000. I'm just hypothesizing, like everybody got close to it. Then if we get close to that aggregate stop loss, they kick in $1 million, up to $1 million if we get there. So they kick in two different places.
And then just for reassurance again, and I know you recognize that's a relatively implausible scenario, but typically you see 5% of your population drive 50% of the claims, meaning they're that large claimant population.
Yeah, I get it. And I guess what I struggle the most with is that we're dealing with taxpayer dollars to provide education.
Right.
And we're having to play this dice game over here with insurance. And I'm not sure that's fair to our taxpayers to have that roll of the dice game over here.
And it is hard because if you look at it from an HR perspective, right? It's part of retention and recruitment.
Right.
You've got to have a good compensation package in order to recruit the best teachers and to retain. Or they're not going to come because you've got to compete in districts around you.
So we just need to be able to afford it. So back to my question, what is something you can do to help us? Because we're in a deficit budget and 85% of the districts are in a deficit budget. So what is something you can do to help? What are some recommendations you may have for us? Right.
Premiums is going to have to be one of them because we talk about.
Let me ask, I'm asking, like, did you all have something that y'all recommended? Or did you have something that you recommended?
I got some, but I'll let them go first.
Okay.
Yeah, I think we've looked at a few plan design changes that certainly don't close the full gap. I think looking at plan designs is a strategy. Looking at your pharmacy plan is a strategy. You know, pharmacy accounts for 35-40% of your overall spend. And as you think about, are there areas where we could handle some disruption where there's equivalent drugs, and is that financially advantageous? We could look at that. We could look at some of the clinical strategies and clinical programs. A large portion of it is going to be plan design, just the benefits. And again, that's what drives a large portion of what the financial difference is in TRS. But we're happy to do it. Olga and I are already working on a project to just see what your claims experience would look like under TRS plan designs. How much of a financial difference would that be? Would it get you to the 481, for example? And so we have our actuaries working on that. We'll share that with your team, just for information purposes. We're hoping to have it for today, but happy to work with you on that, on just the ideas and levers.
Yeah, I was kind of hoping y'all did have that, for today, just to give as much information as possible. But Mr. Escobar, you want to speak?
Okay.
Can you chime
So,
in?
we're really good that we have TRS came in and the big guys from Aetna came in, but locally we have resources here that we can utilize. We know that. And that's the medication assistance program from Texas A&M. Those guys alone can probably reduce our prescription drugs by 20%. Okay, that's a no-brainer. I've seen it happen. We set it up with Clayburgh County. We set it up with Coastal Plains MHMR. And each of them say it's a no-brainer. We got to do it because our top drugs are what, Olga?
on the expenses.
Diabetic drugs.
Diabetics, okay?
So you're talking about if we stay self-funded?
If we still stay funded, even if we don't even stay self-funded, we can go, still bring them in to help out the
Even if
teachers.
we wouldn't go with TRS?
But the beauty about it, if you stay with the self-funded, you get a reduction in prescription drug costs. So you'll save almost 200,000 a year just on drugs.
Are you saying to get the medicines from them instead of CVS?
Right, exactly. We cost shift. We
Shift the
cost
expense.
shift from KISD taxpayer dollars to Texas A&M Medication Assistance Program grant dollars.
But it's grant dollars. How long is it for?
They've been around for 10 years already and they've been doing good. And all I'm saying is, right now, that's a resource. You gotta use it.
Where do you go to get those meds?
What you would go to your regular doctor, all the, you would go to your physician and your regular pharmacy, and or they'll order them for you and mail them to your home, or they'll give you a coupon to get a $20 copay on a $600 copay shot of Ospanic, or the stuff that's lowering their. So that's one way.
So the medicines I get, like at CVS, I would have to change from CVS.
No.
No, I can still get the.
Stay where you're at.
We've implemented that with the auxiliary already. So the auxiliary have had like 4 rounds of services from this Texas A&M center. So they came on board, they did a class, they did some testing
And diabetes
in
education.
diabetes and food, and then those that qualified are assisting them with medication. But it's just that one group. We need to launch this program out district-wide, because the only ones that we've connected to so far is just the auxiliary, meaning custodial and transportation and maintenance. So it is saving us money.
So they're paying for the drugs. It's
But
not
they
an
have
actual
to
pharmacy.
qualify.
You go to CVS, they're gonna help you pay for the drugs at CVS.
Right.
And CVS handles all that.
That's right.
We don't even handle none of that. They come in and they enroll them for us.
But how do they qualify? You said they have to.
400
It's a
times the
qualification
poverty
criteria
level.
through
They
Tennessee,
raised it.
through Texas A&M.
Okay.
So they
not
have
every employee
income
will qualify.
requirements
Not every
of 400 times the poverty level now. And this is available to everyone. We're just utilizing this because it's available and we can reduce our costs. It's a no-brainer. We gotta do this, Even if we stay here or we go somewhere else, we gotta do it and it'll help all the teachers and the employees.
So Phil, so we would work closely with Aetna.
Yeah, well, we'll work with Aetna, but Aetna's not the ones that are gonna, they're gonna benefit from it because they're not gonna have to process the medication
Well,
claims.
It's because we're trying to cut. That's what we're
That's
trying to do.
what
Right, we're trying to shift the expenditures.
Yeah, that's
But-
the only reason why, not.
Okay, so instead of, what's the most expensive drug that we have right now? Probably, what,
I'm not sure right offhand because, but I will say that, we have different programs that we can implement to curb, the cost of people not using like Ozempic. They're using it off-label. When I say off-label, is they're not using it for diabetes, they're using it for weight loss. So we put in what we call smart edits because we want them to be using it to get better from being a diabetic.
okay, I got it right here. This was, the claims on the drugs, anti-diabetics. 30% of the drugs is 188,000 is what we're paying just for the diabetics alone. Okay, that's right here. These are numbers, and so and then you got anti-inflammatory at 37,000. So total of the top 10, we're paying 384,000.
Okay, but when you say we're paying, that's not coming out of our reserves, is it?
No, it's coming out of,
Premiums
they
and
send a
contributions.
claim every month to Sandy and Dr. Pitts, and they turn around and send that bill off, whatever it is that we're responsible for. But through the medication assistance program, it ain't going to go to them.
Okay, so the way we save money there is that we don't care how much it is because it's being paid over here, but they care because they're having to pay it, so our rates are going up.
No,
And so our rates would go down if we started using this
It would
other.
increase our fund balance. If
our
we would
claims will
utilize
go down.
the Texas A&M system, because it's not gonna run through our claim. We're shifting the expenditures to a program so that it does not
That
fix.
number he said does come through our
It
reserve.
currently
Yeah, right
does.
now it does.
Not through the reserve, but it comes through employer contribution and employee contribution. It comes into the pot.
Yeah, we pay those monthly claims that they send to us, prescription and medical. And they'll get the bill and they gotta turn around and send the bill off.
So how many employees do we have currently on that plan? The university plan, I don't know.
We have, like she said, the ancillary employees.
And all of them,
Go
or
ahead.
just the ones that,
No.
but like how many are we talking about?
I'm not sure. We don't govern it. We don't oversee it. All we do is send them over there and whoever qualifies. It's,
So you never find out who qualifies?
So we don't know.
Oh, yeah, oh, yeah.
So then we don't even
Time
know
out.
who
He might.
qualifies.
Time out. We can get that info from them
Yes.
when we need it. We can get that info
We don't have
anytime.
names or anything like that,
No,
but
just
we just need
numbers.
to know.
yeah.
Yeah. we
What
can
we're
get
trying
those
to do
numbers.
is shift, once we incorporate that, then we're tag teaming with Aetna. Because it's not just about letting them get help with just the medication and shifting the expenditure. It's utilizing the internal programs with Aetna for them to have well-rounded care with their needs. So it's not just medication, it's the
Right.
follow-up, the preventative. So this is just a program that, like I said, this past year we implemented. But we need to, go
the
full
teachers.
round
Just
to
trying to pick up
everyone.
as many
and then-
to save money.
And then work with Aetna so that they're
And we
getting
can
all
tell
the
them
services.
we're offering this.
Right.
It's
And it's
free.
only for the ones that qualify.
It's
We don't
only
know
for the
what
ones that
qualifications are.
So
Right.
it's an income
How they
level
qualify.
qualification.
There's an income level,
Do
but
you
as,
know what the income is? Do we have a cutoff or anything?
it'll
400 times the poverty
Okay,
level.
but what does that mean?
And I think the poverty level right now is like 21,000. The poverty, so 400 times. Even if it's 10,000, 400 times is what? 40,000? What is it? 400 times is what? 400,000,
80.
right? On 10,000?
Oh, on 10, yes.
Yeah.
That's
So, I mean,
That's a lot of
it's unbelievable the income limits right now, you know?
So then everybody would qualify.
That's what I'm
400,000.
saying. That's what I'm saying. They just
I don't
changed
think they
those
can be right
rules.
there.
There was some,
Sissy.
I don't think they can be right.
so some teachers didn't qualify, you know? Because of the income, now they raise the income levels. So you asked me what's a way to reduce our costs? That's one way.
Okay, what else?
The other way is, of course, you gotta get some more premium from the folks. I mean, we're,
So, yeah.
but hey,
that's
but here's the
expensive.
other thing. Dr. Pitts, I gotta give him credit because what he's doing is he's just not charging, it's $479, right, Doc?
Yeah,
What do you put-
$479 per employee in the district per
Did
month.
you hear that? Per employee in the district. He's not saying per employee that's covered.
Right.
Oh,
You
it's
got
for
it?
every employee.
So what he's doing, he's smart enough to give you some kind of cushion in there
Banking over here.
that if you did have high claims, that you would be able to help offset it, but he's needing help with more premium.
But why do we have to pay for the ones that are not in the plan?
Because otherwise it'd be way too more expensive for them.
Oh.
And they have to assume that 100% would do it when they give us a quote.
we have a possibility
Because-
of coming
right.
on.
And so that's what their quote is based on. And that's where I got, for years, Christ couldn't understand that. So
If-
what I
if-
want to know is this, we've got 450, somebody's got to calculate, 450 employees, more or less, times 479 is what?
215, 550,
And then times 12.
2,586,600.
86,600. And how many people do you think, how many employees do we have coverage for? Choose our coverage.
Well, at the end of the year was 316,
Okay. So
but in
how-
the summer more came on, so it's probably closer to 325 now.
All right, so now
something
you're
around there.
saying do 325 times 479 times 12.
Is 1,506,000 times 450, or what did you say?
No,
1,868,100.
1,868
100.
100. So there's $700,000 right there
Of savings.
of more expense with self-funded than it
Well,
would be.
I'm gonna go over the financials in just a minute.
Yeah.
But what other, so I want to say before, I don't know if we have any other questions for Edna and.
She ran to the restroom.
Okay.
Okay.
I wanted to go over, because we keep talking about what could we do, what could we do? There's a big piece that we're missing, because we've not increased premiums, and we all know that. We've not increased premiums. We can't look at it one-sided, and our budget, our fund balance isn't sufficient when we're not even enough, even on the employee part. Forget the employer part. We already know we paid $479 for the last 15 years. On the employee part, it would be just one person on each plan. On 3 different plans, one person. The TRS, that's not going to be negotiable. We're afraid to even, and you said it, Mr. Kufal, because we're crucified because employees say that we don't, we're charging them. We've not even jumped $15. We go to TRS, and I know budgetary, that might be where we end up. It's a forced hand.
Kansas City, it's out of our hands.
It is, okay.
And we spent 3 or 4
And-
hours tonight, and we do this every single year.
But that's
when
20
these hours need to be spent on improving our student achievement.
But we're gonna be forced, is what I'm saying. So $20,000, where would our fund balance be? One employee on 3 different plans. These rates, $20,000 on 3 employees is what we're gonna make. Where would our fund balance be? So meaning,
But you are increasing rates.
that's exactly right. So if we go to the TRS, where would our fund balance be, where it wouldn't be a district expense? Because that's gonna be employee money, not increasing employer cost, employee cost. One employee increasing it by $85, another employee increasing it, another employee from $532, it's not gonna be an option. They're gonna pay $13.83.
Okay, that's incorrect. So we had talked about, we can set the amount that we contribute
Exactly.
differently for different tiers. So we can make the premiums that employees pay the same regardless of whether with Aetna or
That's
whether
right.
with TRS. So we have the ability to do that. So, and again, all of these we're going to address when we get to the financials. But while TRS is still here before I'm sorry, while Aetna is still
We're hopeful again, right? You heard it's every 6 years. We're certainly hopeful.
There's one thing I want to say. Olga and Aetna have provided us great service the last 6 years. The question is not about this is not a referendum on Aetna. This is completely financials. Can we save more money with self-insured versus fully insured? So, but again, Aetna is, and Olga in particular, she has been there all the time. Like I have called like almost before 5 o'clock. Sometimes she's gotten back to me on week. I'm very high maintenance. I ask a lot of questions because I really want to know and I want to understand. And she has been patient and they have worked with us through thick and thin. So again, I cannot complain about that, and the service that they have given our district has been great. So do we have any other questions for TRS before we start getting into the financials?
Thank you.
I'm sorry, Edna, before we get into the financials.
Thank you for your
Okay,
service.
Thank y'all.
Well,
Thank
thank y'all. We know this is a difficult decision, and certainly if you have follow-up questions, please feel free to reach out. But we'll be thinking about you guys as you discuss it. We're here to support in any way we can.
Thank you very much. Ricky, can we get the next slide up, please?
All right.
Okay, now I'm gonna talk a little bit about the financials on each side. Do we need a short break? Okay.
Peter, you got 5 minutes.
Oh, well, I guess I better be quick.
I mean, I know it's like 20-year-old kids, I didn't expect to go out and do it. This is irrelevant. This is where my turn.
But just say he goes to TRS. And he
They're
wants,
gonna pay this. If you go to TRS.
the employees won't pay this.
The employee's gonna pay this. Whatever we go, they're gonna pay this, whatever we go.
This is one say that you never have to, this is what if they're gonna pay an employee. But you can't say that your premium is gonna increase before 700.
They're getting the first year was 7.
But what I'm saying now.
My point was, if this is what we ordered, we would have bought it.
This is irrelevant.
We're asking why are we in this situation? We wouldn't, but we've not shifted. So it's not increasing the but that's what
I don't know. That's just what
We turned it off.
The bill?
Of course. Yes, you should have just done that. Sorry. My mind just been. Yes, yes.
Yeah, no, right.
Dr. Holt, are y'all gonna get?
No, I'm good, thank you. Okay, thank you very much. Appreciate it.
Bye-bye. Nice meeting you.
Just in case.
Where do you stay?
I'm driving. It's only this.
Oh, it is. And purpose, or where?
It's not in there. Right outside of Roanoke.
Okay, so you don't have long drive.
No.
Are you going to sit? Sandy, come back to the. Sandy, I'm not even here. I'm not gonna. No, no, no. Take it, take it.
What do you want?
What is your card right there?
Okay. Please tell me when. I think we have a couple.
I don't need. And then, yeah, keep this stuff.
Well, that's something else.
Yeah, they said
Thank you.
Just a word on the street.
No, he doesn't. He said he doesn't. He got, United Health Plan. I said, you better get out of those. Good. Don't get those free ones, because they're not good. He doesn't have TRS, because I asked him. His Medicare. I think
Pretty good at pay, pay covers. All that.
Yeah, but they told me that, really, I don't have, I mean, I get stuff, but I throw it away, because they take it on like 6 months before. By December.
I'm doing it right now.
And Medicare. Yeah, there's a premium. My stomach's not good.
So if I would have stayed with TRS, you can have nothing with 135, and then I'm paying 174.
Huh?
And I never earned that reward working where they took Social Security, where they could have taken that. My job could have taken my insurance with the quarters, and I didn't get covered. The Kingsville, they don't take Social Security. They qualify you. When I worked with my dad, which one? He never, that was being audited right after through settlement.
Are we ready to start?
Yeah.
So you see the slide up there that we have on the financials. I presented a little bit of a different way. Last time I looked at what would be the lowest possible savings we could have and what would be the highest possible savings. So I brought in last year. These are actual numbers from last year, not hypothetical. We were on a self-funded, self-insured plan this last year. We paid $3.38 million, almost $3.4 million. What I did is I worked backwards to see what we would have paid if we were in TRS. And there's some variables there. The one variable is we don't know what plan they would be on with TRS. What I did in those calculations is I put everybody that was on a broad plan in their highest plan with their highest premium to get the most possible we could possibly pay with TRS. There's a good chance that a lot of the employees would be on the TRS primary instead of the primary plus, just because it is cheaper. But if every single one of our employees that were either on broad 1 or broad 2 were on TRS primary plus, their most expensive plan last year, it would have cost $2.7 million for TRS. So the least possible savings we could have had last year, $642,000. Again, there's a chance that it could have been more if some of those employees had been on a lower plan. So the financials, the other thing is could have been on the hook for $800,000 more in claims before our stop loss kicked in. So the worst that probably could have happened is about $1.4 million that we would have saved if we were with TRS last year. So we're talking anywhere from $640,000 to $1.4 million differential before the aggregate stop loss kicks in. The point that Mr. Kufal had is that we have many different costs for our district. The number one cost for our district is employee salaries. That's number one. Number two is health insurance. That's the second biggest cost. And as Mr. Kufal said, and as we're going to be bringing to you this year, we're going to look at all the different costs and what we're paying for them for the kids this year. You have employee costs, so you're paying for compensation, which at the very top of that is salaries. Second is health insurance, but you also have things like stipends that you're paying, retention stipend, and then stipends for athletics and for all of the other academic stipends. And you also have costs that go along with salaries. For instance, you have to pay for everything about like workers' compensation. You have to pay for TRS retirement, completely different than now we're going into TRS retirement, not TRS health insurance. So there are a whole bunch of different costs that we have. And the more that we pay in health insurance, then the less we can pay on employee salaries and direct costs for students and instruction. So that's why we're even here considering looking at what would it be like self-insured. Nothing, again, Aetna has provided excellent customer service. There's no arguing about that. Excellent customer service to our employees and excellent customer insurance to Sandy and I at the district level. The main thing that we're here looking at is cost right now. And again, when we come next Monday, the decision that you're going to have to make is, do we do a short year plan? If we do a short year plan, if we do an 8-month plan, then really the corresponding part to that is we're moving to TRS in September of 2025, if the board elects that, when we come next Monday. If the board elects to renew Aetna for 12 months, then that kind of kicks the can down the road. That gives us an option we can either keep staying with self-insured perpetually, or at any time, like we could go ahead and move to TRS at January 1 of 2026 if some of these changes that we're trying to make aren't proving that we can still limit cost. We can even move to TRS at any time. Basically, TRS needs about a 6-month notice, but the advantage of moving in September is you are rated as a region instead of rated individually. If you move in the middle of a plan year, then they look at our claims for the last 3 years and see how we did for the last 3 years. And most probably we're going to end up paying more if we move in the middle of a plan year because of that. So what questions do you have as a board on the financials and what we are actually going to be presenting to you for a recommendation next Monday?
Well, we've asked Aetna, Dr. Perez asked Aetna, and we're with that, where can we save? What can we do with that? We haven't even given them a chance. You know? Are we in contract with Aetna for just yearly? Is it just yearly what we do?
Right now, well, usually they give you an option to keep renewing every year. So right now we still have at least one more year with them. After that, then we would look at maybe doing another year, or we could even go out for bids. But then when you go out for bids, you're looking at several years and so on after that. But right now, yes, right now we are looking at just 2025 from January to December. And in order to answer your question on what can we do to save if we stay self-funded? Well, one of the things that we're going to do for sure is we're planning to eliminate Broad Plan 2. That was the one that was running at 180% loss limit. So we are planning to eliminate that for sure because it wasn't working well for the district, for our employees. They were having to pay a lot of costs too. So we are for sure doing that. That is going to make a difference. It's hard to say ahead of time what difference that's going to make because what the employees are going to do that were on Broad Plan 2, they're going to have to move to Broad Plan 1, which is going to be lower premiums every month and higher per visit cost every month. And it's hard to say ahead of time what effect that's going to have. So we can do that. You've talked about Phil brought in a very good point, what we can do on the pharmacy side. We are trying to, can we move to the next slide? We got to come back to this because we got to look at the ancillary benefits on the slide, but I wanted to answer Mr. Garcia's question of what we can do. Can you blow that up bigger, please?
Yes, sir.
So this is just the broad plan. So we're going to make some changes. If you see broad plan 2024 and broad proposed 2025, if we make some of those changes, like you see the difference in the premium, you see the difference in scroll down specialty visit from 40 to 45, scroll all the way down to the bottom, please. So you see some plan changes there. Those will move the needle a little bit. And as Sandy mentioned earlier, we are planning to move the premiums up. So that'll help. All of those things will help. Will all of those things get us between $624,000 and $1.4 million? They're not going to get us that far. So, I mean, there's no argument that we're going to save money by going to TRS, but the question is, how is it going to impact our employees? That's something that needs to be considered as well, because our employees, we want them to be taken care of. We want them to be taken care of whether they're with Aetna or whether they're with TRS. If you look at the column on the right, that column there is what eventually premiums need to be in order to keep up with healthcare costs. We are nowhere near there. If you look at the individual, we're going to be very close. Individuals were fine. $83 is where we're going to be at next year. $85 is where we eventually need to be to keep up with costs. But if you look at the next one, employee and spouse, we're going to be at $425 next year, and you need to be at, is that $988? That's a little small for me. That's where we need to be in 3 or 4 years eventually. Right now, the district is subsidizing the cost of employee plus spouse. We are not giving the true premium of what is needed to cover those costs. Other districts, they're all around that of what they are charging employees. You look at employee plus children. We are closer to that. We're at 343. Other districts are around 480. That's what's needed actuarially to cover the costs. So that's not going to be very hard to make up the ground, because children, they don't have huge medical costs. They have runny noses, they break a leg, but they're not going to get cancer. They're not going to.
Oh, God.
You never know.
Yes, but I'm talking average.
Go back to go back 12 years ago, 12, 15 years ago with our history. See what a couple of claims did to us.
Right. I'm not, but I'm saying that generally kids have lower health costs than the spouses do. The spouses are a lot of times the spouses aren't working, and they're the ones that are not as active, and they're the ones that have the highest claim costs. And that, I know you're laughing, but.
What'd you say?
Dr. Fitz, with all due respect,
Like, come on.
I know the reason my wife works is because in this economy, I cannot afford my house, my gas, my insurance, and my food as a single man. I don't know anybody who doesn't live from my generation in their parents' house whose significant other also doesn't work. None of us can afford that.
There is a reason why actuarially every single district charges what they do for insurance with the spouse. There's a reason for it, because there are high claims for that.
So what you're basically saying is more expensive for a spouse than a kid.
Yes.
Is that the bottom line?
It is definitely more expensive for a spouse.
And there's another factor that comes into play here that you're not supposed to say out loud, but if our plan is so attractive that it's bringing in the family as opposed to the spouse's plan, which may not be as attractive, but if they were taking that plan, then we don't have the expense on our side. So you almost want to make our plan a stinker. They know what the spouse is wanting.
Well, from a district contribution point, that's actually true, but we want to provide fair coverage and fair premiums as to what other districts would cost as well. Right now, the problem is that we are providing more than what all the other districts are covering right now. So we don't want to provide any less. We want to be competitive. And the reason why we don't want to provide so much more than all the other districts like we are right now is because that limits us on what we can do with salary increases. That limits us to what we can do on providing instructional resources for students. That limits us on what we can do with infrastructure costs like paying for roofs and things like that. We want to be competitive with other districts, but again, right now, this is an area where we are paying more than other districts, quite a bit more than other districts. So those are some of the things, again, that we can do to get our plan running better. Now, again, I want to be honest with the board. I'm looking at the long-term financial health of the district. And I know that I will need to make a recommendation next week. And regardless, you guys will weigh all factors and you will either take my recommendation or not. But my recommendation next week on Monday, based on, again, the long-term financial health of the district and looking at all costs for the district, will be to move to TRS in 2025 of September. Again, the board will determine on whether you want to take that recommendation, and if so, you will opt for 8 months of Aetna and then moving to TRS, or you will opt to having 12 months for Aetna. 12 months for Aetna will mean that basically you are delaying the decision and you will have an opportunity in the future to move to TRS if you're so inclined, or to stay self-insured if you choose. But again.
So the recommendation though, if we want to stay with Aetna, what would the premium increases look like? And the design, which is what I've been trying to do.
That'll be exactly what you see that I've presented you the last, there's one page for broad plan, there's one page for a narrow plan, and there is one page for high deductible plan. So that will be what I am so that's the other part of what you will have to approve next week. Not only will you have to approve, are we going to move to TRS in September 1 of 2025 or kick the can down the road, but you will also have to approve the plan design, separate vote. And this is what I'm recommending on the plan design. So I brought the increase in premiums before. The board has asked me a few questions before. So if you have any questions on what I'm recommending for next year for changes in the plan design to get us a little bit more competitive, look at the 2024, look at the 2025. And I'll be happy to answer any questions that you have on those.
So you propose the two, the broad and the narrow, next week. And what is the difference? Because I was trying to compare, and I know that the narrow, that it's not going to go up as much, but the benefits are about the same.
The reason why is the narrow is a limited amount of providers. It is the ones that have the deepest discount. So since it is the providers that have the deepest discount, it's cheaper for employees and cheaper for employer as well. So they will pay less. In other words, they're like, for instance, Crispus Bond is not in the network because they don't give as deep discounts as HCA does. So employees can choose, hey, I want to just go to the doctors that give the biggest discounts, so I'm going to pay less. But you're right, the plan design isn't different. It's who's in the network. Who can they go through? That is the biggest difference between the narrow and the broad. And employees can choose, hey, I want either the cheapest plan, still with less providers, or I want to pay more and I want flexibility to go to whoever I want.
Why isn't the A&M system thing that we talked about earlier that no one seems to know how much what the limit is on here? How to meet the requirements for it? Are some of our employees are on it? But shouldn't that?
Phil, do you want to talk a little bit more about that?
But I think I know the answer is that if we have to, Aetna provides through coverage. And so we have to pay for that coverage as if it didn't exist. If it does exist, it's outside the Aetna plan, but it does nothing but save us, the district, money, because it makes their claims go down for this year, and they should come back next year with a lower premium amount because we saved all this money by using that. So it's not really a part of this, but it's something that we would have to push on our own on the side. Is that kind of right?
Yes.
Correct. Okay.
Why didn't we start with the small group? Was that just to try it out?
No, they were more accessible. We have, right. We have to plan it around.
During PD times,
Right.
we said, what can we do with our auxiliary employees and offer them
Exactly.
some sort of a benefit, educate them on health, and that's where we started.
You say auxiliaries with the custodians?
We did custodians, transportation, and maintenance.
So they have to be provided some type of training in order to
Well,
be
it's
considered.
Right, they have a class, and some of them didn't even realize that they were diabetic, and this is their form of finding out. And now they're seeing their doctors and getting the services that they needed, so it's a very good program.
And they see the employee once every quarter to monitor
They
how
follow
they're
up.
doing. And again, it's free to us, there's no charge, but it does reduce claims coming out of our prescription drug program.
Can they do labs? I'm just asking.
They actually.
You know, they do labs,
They came on
yeah,
site
they
and
do.
they did labs.
They do labs for everything there.
And they did help. But we set it up with Aetna on preventative, also with Quest, where it's 100% free with, for employees.
And
Try to
then
take
the-
care of our employees.
And then another way we reduce costs is by having an arrangement with Ernie Gastanera and Stat Care that they can't charge us any more than $125 for urgent care. And that's available to the employees for $30 and $20. And they can go see a physician anytime. So that's another way we've utilized methods to reduce costs. So instead of them getting the full charge of a urgent care, you know, the most they could charge us is $125 with Ernie and $150 with Stat Care. So we're able to reduce our costs.
Are they okay with the plan? Has anyone ever complained about the plan? You know, no, everyone's pretty satisfied.
If,
I mean, because it sounds, I mean, you know.
well, we've had some employees who, on a specialist, maybe a handful, if any, where, they weren't able to get in, but just like TRS said, we made a phone call.
Yeah.
You know, there's delay, is there anything, and then it was taken care of, so, I mean, in the last 5 years, maybe just a
Hey,
handful.
if y'all don't mind, I just want to go over some of these differences that we're going over with Dr. Pitts on the, for example, let's go over the 2024 narrow plan and narrow
bring up,
proposed 2025 plan. And then if you look down there, you go to diagnostic, everything's pretty much the same. You see, okay, the narrow proposed 2025 is the one you look at. And you compare it to TRS.
Yes, that's perfect.
So you got $1,500 deductible, TRS $2,500 deductible. Family deductible $4,500 with TRS $5,000. Individual deductible $7,000, and we're asking to up that amount to help our exposure a little bit, you know, because originally it was at 6,600. Now we moved it to 7,000 because we can. You can adjust your plan that way. So, and TRS is 8,050. That's what the employee would pay. And then family, we're at 14. We're at 13. We're changing it to 14. And TRS is 16. Okay? And then physician visits, $10 copay versus 30. Specialist, $20 versus 70. And then preventative care, they're both zero. And then CVS Minute Clinic, they don't have one. These guys have one. Aetna. Diagnostic X-ray, $50 copay, and then the other one is 30% outpatient after their deductible. So they gotta meet their deductible before they pay anything. So that's gonna be completely out of their pocket, pretty much up to $2,500 versus a 50. The complex imaging, 30% after deductible, and then TRS, 30% outpatient after deductible, the same. And then you got laboratories, 30% after deductible. And if they go to an office, doctor's office with TRS, 0. With Quest, if they go with Aetna, it's 100% paid for. They don't got to pay nothing at the lab for the lab. And then outpatient, 30% after the deductible. Okay? And then you got inpatient, pretty much the same, 30% after the deductible. But remember, the deductible is $1,500 for the narrow plan and $2,500 for TRS. Okay? So, and then here, ER, 30% for the narrow plan proposed, 30% after a $350 copay. So we changed it from $250 to $350 to try and get them not to go to ER instead of an urgent unless they have to. That's cool if it's life-threatening. So they pay 30% after a $350 copay. Over here with TRS, they'll pay 30% after their deductible. So they got to meet that $2,500 deductible first. Okay? And then a freestanding ER, they got a $500 copay and 30% after the deductible. And so retail generic, $5 for the narrow, 15 copay and 0 copay for certain generics. And then it's pretty much, then you got retail preferred, they got 30%. There's no deductible on with the KISD. And with Aetna, with TRS, 30% after the deductible. So they got to pay $22,500, then they'll get 30%. And then the next one, non-preferred, 35% is what we pay, and the other guys 50% after their deductible. So you can see there's going to be a lot more expenses on the employee side for these certain things. And then mail order, 35%, and then you got TRS, 30% after the deductible. And then the mail order, same thing, 45% for KISD, 50% after the deductible. And then down below, you got the diabetic supplies and insulin, $0, and then you got certain charges there for the TRS, you know. And so that's that plan. So if you go back to the other plan, the broad plan, and it's pretty much the same thing if you go over it. You got the broad plan up there?
Yes, and I think you're right. It's pretty much similar difference. I don't think we need to go through each.
Okay, all right. So, but at least y'all sort of know what the difference is going to be. But here's the other thing. This is what I want, you know, and Doc and I went over this too. But you got to make sure you understand. This is what I wanted to give you. We got a $642,000 savings in the first year, which is really good. And we used the claims for 2023, 2024. But the claims, they average from in 2023, the ending of 2023, we paid $3,076,000. You know what? Check it out. Just look at this. That way y'all can just check it out and see.
This is something that has been presented to the board at some past board.
Yeah. What were the claims we paid every year for the last 15 years? And those older ones, we had like 450 employees on the plan. We had a lot more employees on the plan. So, but that was a good number. Doc used $3,389,000. Can you go back to this one, sir?
What's going on?
That would be 3A.
Oh, yes.
Yeah.
That one?
Yeah.
Yes, sir.
Okay.
So we're saving $642 the first year. But the thing is, they're going up 10% a year for the last 5 years. But what if they go up higher? But I use 10% a year.
I think it was more like 12. I saw some things.
I use 10 just to make it so we could sort of know where we're going to be at in the future. So the first year, TRS was 2,747,000. 10% of that, 274,000. So I added that on. So we're at 3,021,000 after the second year. In the third year, we're at 3,323,000 with TRS. In the fourth year, we're at 3,656,000 with TRS. And in the last year of our we're at 4,022,000. That's just, and we got to stick with them for 5 years. I'm just showing 10% a year.
That's the scary.
But that's my
That's the
job.
scary part, but let me interject that healthcare costs are gonna go up no matter what, no matter who we're with. They're probably gonna go up anywhere from 7 to 10%. Even like our plan last year, we went up 10% on what our expenditures were last year. That's what it was for us. Like, if you look at what our claims were last year and our claims this year, the district had to pay 10% more this year than they did last year. So that is a certainty that every year costs are going to go up. No matter who you're with, costs are going to go up. So yes, is it guaranteed with that? But again, Aetna showed in their presentation that there are things they can do, like what Mr. Garcia said. What can we do? You can make our plan exactly mimic TRS's plan. In other words, you can make the plan run leaner. Right now, Phil was pointing out how much less our employees pay than what all TRS and what other districts are paying. If you want to make the cost more, then what you do is you increase the co-pays, you increase the amount out of pocket. That's how you make it run leaner. There's no magic to it. If you want to have lower costs, there's a couple of things that you can do. You have to change the plan. And what we're doing this year is we are not completely changing the plan 100%. We are changing the plan, let's say 20%, and then next year another 20%, and next year another 20%, because we don't want our employees to have a shock. We don't want to completely go over to having them pay a whole bunch more premiums than what they're paying right now. And we can do that incremental increase in premiums regardless of what we do. What we can't do is we can't incrementally change the plan design. If we go to TRS, they're going to go right to that plan design. In other words, they're going to pay more. They might pay 30% instead of 20%. They might pay $50 copay instead of a $20 copay. So those things you don't have control over. The main reason why I am recommending, or what I will be recommending next Monday, is number one, it is a decrease in cost, which allows us to better use those funds to educate our students and pay employee salaries, and they have potential capacity for paying salary increases in the future. But also it is exposure. So right now, if we get big claims, the person that has to pay is the district. We do not know, like we could have had to pay $800,000 more this year than what we already did before our stop loss kicked in. And with a fully insured plan, you know exactly before the school year starts how much you're going to spend. The only thing that's variable is if another employee comes on and they choose this plan over that plan. But by June, TRS says, this is what you're going to pay. For each employee on this plan, you pay this, and we already know ahead of time, this is what we're on the hook for. If we get large claims during the year, it doesn't matter. We already automatically know at the beginning of the year, when we're doing the budgeting process, I know exactly how much I'm going to need for health insurance. It's not, is it going to be $600,000 or $1.4 million more than what I've already budgeted? It is what I take to the board. So it limits that exposure. It limits the risk that you are susceptible to. So you don't have to worry about at the end of the year, do I have to kick in another $600 to $1.4 million? Before I go to the ancillary benefits, are there any other questions that the board has of me or Phil or Sandy or Olga? Yes, sir.
So you're saying that you're gonna make the administration's gonna make the recommendation to go with TRS?
In September of
Okay, well, that's
2025.
what I was gonna ask. Say that the board says yes. What is the time frame? Are we still gonna be self-funded to a certain point and then TRS?
We would still be self-funded until September 1 of 2025. And if the board chooses to go with Aetna for, let's say, 12 months instead of 8 months, then that kicks down the can down the road. That doesn't mean that we can't go to TRS in the future. That just means that for sure, we're gonna be with Aetna for all of 2025, till December. And then, let's say we come board meetings in the future and the board decides, hey, we wanna move to TRS at this time, you can move to TRS at almost any time. It's just that they need 6 months, approximately 6 months ahead of time. The disadvantage you have of moving in the middle of a plan year is that they're gonna look at us individually, and if they see that we had high claims, they look at the last 3 years. It's hard to say that, I mean, it's possible, but I've asked them and they've said it's rare, very rare that you're gonna pay less if you go in the middle of the year. You're probably gonna end up paying more for just that short portion of time until you get to September 1. Then when you get to September 1, then you're rated in the pool again. But that does not limit the option of us going in the future. So
What's the recommendation gonna be?
my recommendation, I'm telling you ahead of time, my recommendation is going to be to move to TRS in September 1 of 2025. Again, and the board will have basically two choices. Do I renew with Aetna for 8 months, which means I'm going to TRS in September 1 of 2025, or do I renew for 12 months? If you renew for 12 months, you're locked in with Aetna for 12 months, but then after that, you can either choose to continue self-insured or you can choose at any time to move to TRS. So those will be your choices next week.
I have a quick question, actually for Dr. Holt and Dr. Sandoval. Olga explained this, and I think we all can agree that this is for a recruiting purpose. The fact that we have this other insurance and not TRS could be a selling point. Do you see it that way, Max, as well? I mean, do you think we have good insurance where this is an extra carrot, an extra incentive, or you don't think it's going to make a difference as a potential employee picking KISD over another school district?
If you're a younger person coming in, a young person who doesn't have medical issues or anything, I don't think it's going to pay too much of an issue with them because they have no medical issues. Once you get older people, they're going to like this insurance.
Which one?
The Aetna. I mean, it's going to keep.
The one we have now.
Right,
Yes, okay.
correct. And the fact that you're not out of pocketing much, which I see it, but that's my opinion.
Well, no, that's what I was asking.
Well, you know, when I look at it, really point, I mean, we really should have been selling this the whole time as a recruiting point. But once we go TRS, if that happens, then we become like everybody else runs, north, south, east, west. So, you know, again, you know, that's something to look at, I guess. But I see the point that we're making tonight as far as the cost. But once we become like everybody else, then we're having to really bid on getting quality people here and keeping quality people.
Yeah.
Because they can say, I'll go 10 miles down the road, it's the same thing I mean.
And if you do go that right TRS route, then people are gonna want to say, well, then pay me more.
Well, the two go hand in hand. The more that you put toward health insurance, really the less you can contribute to salaries because we only have a certain amount of money. So employees, I would say yes, it's a selling point, but number one, they look at salaries first. That is the first thing that they look at. And if we hamstring ourselves so much that we're putting so much into health insurance that next year we look at, hey, we can't even afford a raise because we're broke, we don't have any money, that's going to be a problem. And I think that we have worked so hard to get competitive. Like I would say 4 or 5 years ago, we were not competitive in salaries. We were not. And we have worked so hard to get our salaries to be competitive with all the other districts in our area, to be at market value, that we don't want to go backward. We don't want to get to the point where we can't afford salary increases as well, because I think that they look at that first thing more than anything else.
Also, Dr. Pitts, is that more salary that they're making, it's going to be spent on healthcare. Right?
That's not your situation too.
Yes. I mean, you're right. You're right. It's a difficult decision. There's no easy answers right here.
And I know, Dr. Holt, you've met with some people who have said, yeah, but over here I'll make more. And then you've said, yeah, but we pay more towards the insurance. And they don't see that as easily as they see the salary. You have to really put the math out there for them.
And we've had employees that come from other districts and have said it also reversed, like, I'm being paid competitively and I'm saving because I was paying this much on insurance. So it's an incentive even after the fact, where they see that it's lower premium, so they got better salary and a little more even in their checks because their insurance isn't that much. So they got 2 for 1.
They don't know it
But they don't know it until they get it.
But wasn't Edna gonna be working on some figures or something?
That's what I was hoping.
I mean,
Working on what?
are we really gonna be ready for Monday? If we're gonna be
Well,
waiting
this is
on
the thing,
Edna?
this is the thing. Dr. Pitts has already recommended, he's gonna recommend TRS. I'm gonna tell you right now.
No.
Now we can.
Well,
We can't.
he's already made the recommendation.
I understand, but we can't.
You know what I'm
take
saying?
We can't take any kind of vote.
The only thing
We're
is
gonna
this, well, not voting,
No,
still
no.
my opinion, but all right, I will say it. Is that, but you can read between the lines.
Right.
Okay, but I think we owe it to Edna to give them an opportunity to be competitive, more competitive. Okay?
And I think we owe it to ourselves
Yeah.
to have more time.
Yeah.
We can't make a decision
Right.
in 4 days.
No.
And this decision doesn't go away. We've talked about it
How many
more
times?
in-depth
Many
tonight
workshops.
than we have ever before.
And you're right, Brian, we're spending too much time, you talk about 8 years, I think, we gotta get back to academics.
Yeah.
That's, we're over here doing, I'm gonna go over there because they're paying, no, what about academics?
I just hope
You're right.
we don't forget
Yeah.
this discussion as we move forward down the road, because the day is coming
Mhm.
when we're not gonna have a choice, it's gonna be made for us. And I wanna be ahead of the curve before then, but I personally also have a real hard time on this short of a string.
But I do agree that premiums might need to come up.
Well,
they're
and-
gonna come up.
And I think Dr. Pitts has to make the most fiscally responsible.
Right.
That's my
He has to, that's his job. He has to say, what's gonna save the district money? He's a numbers guy, and he has to put it out there that I have to make that recommendation. So it doesn't mean you have to agree with it, but it does mean that he has to say that. But I wanna look at also, more so, which I've talked to Phil about, and I've talked to y'all about, and I'm telling Etna as well. So if you look at the different plans, I mean, I don't even think any of us have us memorized, like when I go to the hospital, how much I'm gonna pay for deductible, and, I mean, all of a sudden I just get the bill, and I'm like, I thought I made the deductible, So they don't know, I don't know,
I don't know.
every time I go to the hospital, exactly what that's gonna be, right? So it won't hurt, I guess, as much as it would if we completely take that away. So we've got to really look at designing the plan where it's not really gonna, and it's almost like a car insurance. Remember I said, can't I pay a lower premium? Why am I paying such a high premium? And it's because I have this high or low deductible, right? Like I get in a car accident, instead of paying $250, now I'll pay $1,000, and my premium goes down. And I never thought about it that way until years ago when they educated me about it. It's like, yeah, why did I get that low premium? And I never had an accident during that time. So I could have been saving money. We've got to educate our staff on the wellness and making sure that we're using those prescription, the programs that are also gonna help. I mean, if they can take care of their health, we can take care of our health, then we won't have to see the 30% after deductible and try to figure this whole thing out all the time either. But I know the premiums, I mean, you talk to anybody, premiums are going up no matter what in health insurance, no matter where you're at. So it just depends on how high we want to go. Like, I like the phase-in model, and let's start a little bit, because there hasn't been an increase in 15 years or something like that, which is a blessing. But I don't know that everybody realizes that part, is that we're at a point where we've got to think of the financial state of our district within the next couple of years, and maybe waiting to have this conversation again later, but we're still gonna need to make some decisions because the 89th legislature is coming up. And hopefully the legislators have heard us enough to say we need money, the districts need money. I don't know how much they're gonna help us with, I mean, but maybe we might be able to make more of a decision, but we're gonna need to do something at least to start saying, this is serious, we've got to make sure that our district is financially stable. And this is one area that we have to look at as much as we hate to.
I don't know when it would be a good time to start. I mean, they do a good job of meeting with campuses and communicating, but when is a good time to actually get into this right now and not 2 or 3 weeks before it happens, or 2 or 3 board member meetings before it happens?
Because no changes,
They have to
the
go.
premium wouldn't happen until December.
Right now, nothing is gonna change till January.
Right.
Nothing's gonna change
As
till
long as
January,
they
so.
go early, that.
We meet with them in November, so we're having open, that's why this has to be done, because the software has to be changed to reflect what is being presented for Monday as for approval. And then we meet with each employee in November. We've got the schedule tentatively out, so like the first week in November, we go to the campuses and meet with each one.
And I'm real big, because I'm old school, I'm real big on these meetings, on this, a faculty meeting, having that on the agenda, where y'all present, if there are any questions, you can set up appointments, or, you have a table set up on the side. This way, we reach a whole group of people, they've heard it, now it's up to the individual to go and ask the hard questions. What's the difference going to be? And that way, we're not getting calls on anything, because they already know it up front.
We have 1 day assigned to every campus, and I think it's 2 days with HMP. So it's an all day thing there.
Thank you.
We've
They'll
got
have them
multiple
sign it.
people.
And because we've got to make some changes, we're gonna be bad guys. And I have a hard time believing anyone sitting at home watching this and to see that, we haven't taken this lightly. We've struggled with it, and I appreciate the time that we've given to this, because this is just gonna get more difficult as we go. But I'm glad we've had this discussion and we've had this meeting.
We've got one more small item there. Okay, so this is on a lighter note. This should be, so if you, no, go back to that same slide, please. So we need to look at ancillary benefits. So the board also will approve ancillary benefits that are district paid. Ones that are employee paid, that doesn't come before the board. That's not district money. But these are the ones that we are currently paying now, and this is going to be my recommendation on Monday for these ancillary benefits that the district pays for, and I want to answer any questions you have. Right now, we have telemedicine across the district for every single employee and their dependents, regardless of whether they are on a plan or not. And it costs the district $20,832 a year. It is going to be administration's recommendation to continue that for next year. You see the retained. We also have a life insurance benefit of $50,000 for employees. That is $29,280. And we're recommending to keep that for next year. The one that we're recommending to remove for next year is we have a $50 monthly ancillary benefit for people that are not on a plan. That, in other words, like, we will pay $50 toward dental insurance or something that normally would be paid by the employee because it's not district paid. In the past, we have paid that for employees not on a plan. Other districts do not do that. We are under no obligation to do that for employees. If they want to be on a plan, they can be on a plan, but we are under no obligation to give them extra money for not being on a plan. That would save the district $26,400, and we're recommending to remove that next year. That is. So, do you have any questions about any of those three?
One quick question. The life insurance benefit, that is for employees while they're employed.
Well,
is there any packaging of that? If they leave our employee, can they personally retain it and pay for themselves?
No, if they purchase their own policy.
They can purchase their own health
But they don't
life
take-
insurance
they can't
policy.
take this.
Right, they can't take the district's one with them, but they can purchase their own.
Okay, for next week, the telemedicine.
Yes.
For all employees.
Yes.
I'd like to know, like, do we have a lot of people that take advantage of it? Is it even worth it? Because I mean, most people, I would think most of the people have insurance already and may not be using the telemedicine. Or do we really have a lot of people that use it?
Well, we do need to increase it, but it's something that it's very important because it would decrease employee costs more that they use it because it's so much cheaper to use that, and it would decrease district costs. So the more that we push that, the more that is gonna save, it's gonna help on both sides if we do that. So that is gonna reduce costs by keeping that.
And that's a good point, because as we have to increase out of pocket, this will be.
It's gonna push them.
More
towards this
employees
more
will
and
want to
more.
go to that if they have to pay more, right, to see them in person.
So we're taking away that we're giving.
And it keeps your employees at work.
Right.
You know, instead of them having to miss to go on a doctor's appointment, they do it by telephone or their kids. And they don't
Very
gotta skip a
convenient.
day, you know, and they can get their kids taken care of right
Around the
there.
holidays, we see an increase too, because the physicians are open.
Yeah,
So.
it helps a lot.
During the holidays, I think
It
is
does,
when we've
yes.
gotten calls of the rights.
Any other questions from the board? Thank you for your attention and seriousness in this matter, because Mr. Kufal's right, it really is an important decision.
Hey, can I add something at the end?
Yes, sir, absolutely.
Hey, number one, congratulations. You all picked a good head coach and football team, football program. We're 4-0, man. Good job on picking the coach, number one. And I want to commend y'all on a lot of the improvements that we've been seeing as y'all been going along. I know you get a little slack from some people, but we see what you're
Get on
doing.
Facebook.
And y'all are doing a good job. Keep it up, please.
Get on Facebook.
All right.
All right. Item number 7, the board will enter into closed session in accordance with the Texas Open Meetings Act, Government Code 551.071 and 551.074, to deliberate and consider the following: A, discussion regarding superintendent evaluation. We are entering closed session at 8:38 p.m.